think many people already heard about biotensegrity and also the lectures, but it's very worthy you to listen to Dr. Lenny's presentation about biotensegrity again. Yeah, they are the founders of biotensegrity. Yes, originally. Okay.
And today, for people who are online, we had some technical problem yesterday, and we have solved it. So should be okay right now. If anything, just tell us. And today we have translators, Dr. Dong Shengchun and Justin Chu. And yesterday we have Dr. Wu Shuyi. Yeah, so we'll be thanking the translators. And that's welcome, Dr. Lenny Howard.
Yeah. Hello, everybody. Can we change this? Wait, either that or I have to take my hearing aids out.
Okay.
Let me just take out my hearing aids. Okay, now that's better. Hello, everybody, and welcome. I'd like to welcome all of you I consider fellow explorers. What are we exploring? We are exploring the way that we are put together. We are exploring what is the truth. Where is the truth?
我们想要探索什么才是真实的。
Differently based upon our experience. So the more experience we have, the more knowledge we have, the
这些
better
真实主要是依据在我们的经验上面，
and not with our little eyes that we can only see what we can see.
根据我们的经验，我们可以得到一个更纵观的
Know
结
what
果，而
you
不是
see,
只单从我们的肉眼所
see
见。
what you know. If you don't know it, you don't see it. So my
但假如我们没有这方面的知识的话，我们就
to a new way
看不到
of looking
这
at
些真
things.
相。
And maybe in the times to come, you too will find new and different way approaches to the same problem. So we're going to talk first about biotensegrity, and that will be the thing. So I don't know how this works. I don't think. Oh, is it on? Patience. There's no music. There's supposed to be sound with this. It worked in practice. Okay. What that movie was supposed to show was that how we evolved from thinking of something as a bone to a weapon. We changed our idea. So now I have what I call Lenny's law. I think. Oh, if what you do the best isn't working. So a couple things are true. One, you made the wrong diagnosis. You thought the problem was there, or you thought this. Or you made the right diagnosis. And I don't know why this doesn't work. At where? You made the right diagnosis, but you chose the wrong treatment. That's reasonable. We all have done that. So the answer is do something different. Don't stay stuck. This is what you need to do. And if you don't do it, I can't help you. No, it could be that you are wrong. Okay, I don't know how this works. Jonathan, maybe you could help me. My trusted grandson, Jonathan, is always here to fill in the blanks. Because you get to a certain age, you know, I have to tell my great-grandchildren what to do. They tell me what to do. Okay, so the first thing we have to know is that the same nerve, this is so very, very important. And where it is going to be important is changing the way you think about the body. So the same nerve that supplies the muscle is the same nerve that supplies the skin and the joint below. So if you do something to the skin, you are really affecting all the structures below that. And that's called Hilton's law. There's another law, Sherrington's law, but it's basically based on Hilton, who was an Englishman. And he said that everything is interconnected. There is nothing in our body that doesn't relate to some other part of our body. So you may say, oh, I'm a specialist in this finger. What does it have to do with the toe? Well, I hope to be able to explore that with you. So this will let us understand what tensegrity and how it works in the body. This is the most difficult concept to get in your head. And I'm going to explain it to you as I understand it. That does not mean that's that way you have to understand it. Each of us has to bring it into themselves to understand what they're looking at and how it affects them. So what I would like to do in this brief time we have together is change the way you think about things. We all are mechanics, that's all that we are, you know. And two, develop an integrated approach to how we're going to treat the problem.
第二这堂课，希望我们可以得到一个比较整合性的策略去处理你病人的生物力学问题。
Contributes to the neck. Maybe the feet contribute to the neck. Everything is integrated. There is no such thing.
不选身体的一个部分，其实是跟另外一个部分有关系。
A toe, an eye, an ear, everything is going to affect everything else. So
任何身体的部位都有可能影响身体另外一个部位。
is to try to look at life holistically.
第二这堂课，我们可以用一个比较全人的角度去看病人的问题，并且处理他们的疼痛。
What is tensegrity?
这堂课的最后，我们希望可以得到3个目标。第一个，了解什么是 tensegrity。
As mechanics, we have to understand the way the body is put together.
只有力学，我们要了解我们的身体是怎么被组成的。
It is a body.
我们不是只是单纯看单一关节、肩关节、膝关节，而是把它当成一个整体的人体，这样子的个体去看待。为什么我在意 biotensegrity 呢？
How do I use tensegrity
我怎么
to
去
make my diagnosis and to do my treatment? Very, very important. What is tensegrity? First question, what is it? So let's go through that. Tensegrity is compression elements in a sea of tension. Sounds really nice, right? Poetic. What does that mean? Let's put it another way. Muscles move bones. And the compression element are the bones, which are the elements that carry the weight or keep the stress. So basically, our body is made up of two things. We're made up of soft tissue that will transmit the energy from one part of our body to another part of our body. And the sea of tension, which is muscle and fascia, don't forget the fascia, are continuous tension strands. So let's look at that and maybe we can see. So when you look at a crane, here's this little crane, which I'm always amazed at. In Israel, we say we have two birds, and they're both named crane. One is the crane that brings the baby, and the other crane is the crane that builds the building. And wherever you go, you see a lot of babies and a lot of cranes. Okay, so you see, let's go back one, please. You see, you have the straight lines, which are, I'm going to call bones, or the stress element. And then you see the diagonals. They are called the tension element. They take the stress off of the upright and pass it to the next one. And so when you look at these type of things, you'll see how it lifts the weight way off of center. How do you lift weight out here when your center is over here? What's doing that? So here it is, this beam must weigh 2-3 tons, and it's lifting it 20 stories into the air. How is it doing that? Why doesn't the crane collapse? Why don't we collapse? We're human bodies, and we'll talk about that. So here you have a roof. I know you don't have much snow here, but where I live in Colorado, we used to have a lot of snow. We used to go skiing a lot. So you see this roof, that is 5-10 tons of weight on this roof. How does that roof handle that weight? Now, when the sun comes out, half of that snow is going to melt, and the other half is going to be on the other side of the building. How does that transmit the weight from one side to another? So here is a bridge, and every time you see a bridge, your mind is going to go right to tensegrity. You can't see things anymore like you used to see it. You're going to see it totally different. So what do we have here? We have the tension elements, as you can see, and you have the stress element. Next. So the question is, how much does the weight weigh over there? Jonathan, put the pointer on the first part. How much does the weight weigh there? How much does the weight of the thing weigh in the middle? And how much does it weigh at the end? The truth is, it weighs the same throughout the structure. It is a 2-ton truck. It weighs 2 tons when it first goes on the bridge. It has pressure of 2 tons when it's in the middle of the bridge. And at the end of the bridge, it still only has 2 tons. The pressure and the weight are spread out throughout the entire structure. Very important. Next. Okay, so now the question we have to ask ourselves is, how do young people, you, become old people like me?
接下来我们讨论一个年轻人是怎么慢慢的变成一个比较年长的长者
And now I
呢
look？ like me. I look in the mirror. I go, who the heck is that? I don't know who he is.
我举我自己当例子，当我看到我的镜子当中的我，我想说，我是怎么成为现在的我的样子呢？
How does that giraffe hold its head up so high?
长颈鹿是怎么把它的脖子举在半空中而不会倒塌呢？
muscles to hold that head so high.
其实就是靠我们的筋膜肌
How
肉
does
的
that
张力去
bear
达到这件事
stand
情
on
的。
one foot? The bear, I mean, he's off center. You can see how he's off center. How is he balancing?
这只图片当中的熊是怎么单脚站立而不会倒塌呢？它是如何做到的？
And here's this woman standing on her tiptoes. She has a weight way away from
图片中的
the
女性，她把一个婴儿举在半空中，踮脚站着，
is trying to pull her on her face and drop the baby.
重力试图把这个小孩往下拉，但是她是怎么让她维持这样的姿势而不会倒塌呢？
Where do we see it? We see it in Israel. We have in Jerusalem this.
在耶路撒冷以色列，我们有这样子的建筑，然后在旧金山我们有这样的金门大桥。
This is Nielsen's integrity model.
这是一个 Nielsen 的 Biointegrity 的模型，我们可以看到 Biointegrity 的展现。
Why does this not work? Or why does it work?
是什么东西把我们分离的？
Gravity.
是重力。
And gravity is the thing that is pressing us down. So let me
这就是张力是把我们往下拉的。
What? Oh, okay. So let me ask you a question. What is the first thing that you put on in the morning and the last thing that you take off at night? I'm willing to take an answer. And those who have heard this lecture before have heard this question before. Anybody has any idea? Raise your hand. Nobody knows? Oh, the first thing you put on in the morning is your feet. You put your feet on the floor. And what's the last thing you do at night? You get into bed. What do you do with your feet? You take your feet off of the floor. So the first thing that you put on are feet. And the last thing you take off are your feet. Now I'm going to give you a Chinese thought. And you all have heard it 1,000 times. And you accept it as true. So let me give it to you. It's by that man in the 4th century of the Common Era by the name of Wu Tao. I think I'm pronouncing his name correct. And he said, every journey of 1,000 miles begins with a single step.
一个中国谚语说，3兆千里始于足下。
Taiwanese? Okay, I assume that you all speak that language. I
我
hope.
假设你们都跟
So
中
the
国人讲一样的
answer
语言，
is that true or false? All those who think that's true, raise your hand.
每件事你都要想是真实还是假
Good.
的。
All those
请
who
举起
think
你的
it's
手。
false, raise your hand.
如果你觉得是假的，是错的，请举起你的手。
Jordan has it. It is false.
这
It
是错
is
的，
not true.
这不是真的。
So I'll repeat the riddle again.
我再重新讲一次这个俚语。千里之行始于足下，从你的一只脚开始，
False.
你觉得是真
Why
实还
is
是
it
假的？
false? Every
为什么是假
journey
的？
of 1,000 miles begin with a single look. You cannot
这件
walk
事情
unless
开始
you
于
turn your
第一个
neck,
第一眼。
your atlas, in the direction that you're going to walk. Now, philosophically, which I'm really into, philosophically, there's another saying. Any port is good for the sailor who doesn't know where he's going.
美语海
So
港
if you
对
don't know
对
where
方
you're
说
going,
我是好
or
的
you，don't know how to get there, it doesn't matter where you are.
不管在哪里，只
So
要知道
you
方
and
位是哪
I,
里就
as
可以。
humans, we turn our neck before we start to walk.
在我们走之前，我们会启动我们的脖子。
Absolutely. We
这
are
是
putting
tensegrity
pressure on the
的
neural
实现。
cord in our neck, the atlas, and we
从
are
atlas
sending
脊椎
a
传动我们的
stimulation
脖
to
子，
our leg to move forward.
然后它会
And if
接
you
着刺激我
watch
们的脚
people
就继续
walk,
往
which
前
I
走
love。to do, you will see them, and
你
you
会看到
watch
他
a
们，
blind person walk.
你看到盲人在走路的时候
really
非常的厉
fascinating.
害
Like，this, looking for his way,
他拿棍子去寻找他的
versus
方向
a。young person walking or me walking. We walk differently. So
所以
one
年
of
轻
the
人和老
things
人，他们
we're
我们看得到的人，明眼
when
人
you
是
go
不一样
back
的
to
方式走
work
路。
is to look at people's walk and listen to how they walk. You'll hear steps you'll hear
我们要眼睛和耳
you'll
朵去
see
看和听
physiology, you
病
will
人
be
怎么样走
able,
路，
like Bjorn said, to understand what's really going on. If you
你就会
don't
知道
look,
到底是发生了什么事情
and。you don't see. You see what you know, and you know what you see. If
你
you
看到
don't
你所知道
know,
的，
you don't see.
你会了解你所看到的东
Okay.
西。
So let's go forward. So the question is, these are going.
是什么把我们
First
组
of
成
all,
在一
is
起
it
的呢
muscle?？
是筋膜和肌肉吗？是骨头
Or
吗？
maybe
又或
we're
者
told
是
that's
韧带
not,
呢
or？ bones. Or maybe it's ligaments. So let's investigate that in a tensegrity fashion. So let's investigate. Is it muscle and fascia? Now let me
那我们
give
开始
you
探讨这个
some
问题。
mechanics.
是肌肉和
Okay,
筋
so
膜
here
吗？
is our body.
让我们讨论一下
It's
生物力学的
bones,
部分。
muscle, and fascia, correct?
我们看到这个红红的部分就是我们的肌肉
Everybody
和我们的筋
Okay, so
膜。
let's look at the mechanics of it. You and I, in kinesiology, and all of you are physiologists and scientists,
在座各位都是科学家或是跟物理医学相关的
is by
人
like
士
a。crane.
我们知道我们的肌肉它主要是用一种滑车的机
The
械
muscle
的
is
理
here
论
and
去
over here,
去移动
and
我
it
们的
goes
骨头
through
的
the。joint or through the, we have two joints. Some of us have three
那其实
joints.
这个理论就
whatever
跟我们
it
的
is.
要告
But
一
that's
样，
what
是
we
利用
were
力比
taught
例
in
矩的理
school.
论。
And it gets in our head. Oh, the joint is wrong. Something is wrong with the joint. So let's do surgery on it and fuse the joint. That will solve the problem. So
但是
let's
却有人
solve
觉得
it,
说要解决
right?
关节的
And in
问
the
题，
foot,
就单纯的
there's
把它
a
融
whole
合在一起就好了。
surgery
但
called
这
the
就是大
Pulling
错特错的。
or the windlass motion, where the muscle, the gastroc muscle, with the plantar fascia, is pulling the foot up. Is that true?
我们原本会认为说
Let's
要
look
移动我们的脚跟，就是我们的腓肠肌利用那种铰链或者是这种杠杆的原理去移动我们的脚，但是这是不是这样子的。
It was okay. Okay. Well, number one, if you would do your muscle testing, if you do your muscle testing,
当我们
and
做
they
肌力
have,
测试的时
many
候，
people got their PhD in these things.
很多人因为这
What
样
do
得
we
到了
find?
博士的学位。
To move a 20-kilogram part, which is 40 meters, it should really be millimeter long, requires a
去
muscle
移动一个
reaction force
20公斤的身体部位，
1,600
距离我
kilograms.
们的中心
That's a
40公分
lot of
长
weight.，
需要1600公斤的力量。
Erectus muscles, which are one of the strongest muscles in our body, can only generate
可是我们的竖脊
200
肌
to 400 kilograms.
最大，
How
在
do
一
we
个
stand
健
upright?
康的人当中
It
只
would
能
take
产生200到
1600,
400
and
公
I
斤的
can
力
only
量。
produce 400 because I'm in great shape. Then I need 1,600 more kilograms to move.
那
Where
我
am I
们想
going
到
to
我
get
们的
it
肌肉最多只能产生400公斤的力量，我们是怎么？
from? So maybe what's really holding us up are our bones. The heck with the muscle. It's our bones that are doing the job. So maybe we're like the igloo or like the Lego. How we're interconnected. You know how your kids play with Lego and they build these beautiful buildings. And I had a patient who worked in the Lego company in Denver many years ago. And she used to bring me big black bags of Lego, which I gave to my son at that time. And they thought nothing of it. They made models of it. They threw it away, whatever. So maybe it's Lego. What happens to the igloo when it has pressure, sun, some kind of external force? This thing doesn't work real well. Force on it. What would happen to the igloo if we're held together by bone? Next. So we see a full yard of bones. None of them are together. They're just bones, period. So bones are not going to be the answer to our question of how we stand. Okay, so you know what? Maybe it's ligaments. I'll give you ligaments, hold our bones together. It helps with the muscles, on and on and on. But no, it can't do that. Why? Because a healthy ligament, that means you're 15 to 20. You haven't eaten much carbohydrates, much sugar. You get out, you play, you exercise, you're young. The most you can generate in the ligament is between 45 and 125 pounds per square inch. Great. The knee joint, that most important joint, that doesn't have any interlocking situation. It's just hanging out there, has a strength of 494.6 pounds per square inch. All of this was not done by me, believe me. This is all done by people who got their PhD in measuring these things. And so the knee can absorb downward forces of 7 times the body's weight. But if I put it under stress, it snaps. So what happens to the ankle joint? Great joint. It's got locking. If you think of the ankle joint, it's held together by bone. It's got muscles around it, a lot of ligaments and all that. And yet people sprain their ankle. How is that possible? Because the answer is that the force put upon it in a twist is more than what anything can carry. So that doesn't work. So the question now is, how do we stand? So here we have an x-ray of a ballerina, and she's on point. That means I can't do it anymore. I don't know if I ever could. She's standing on her toes, and she's standing straight. That's what the foot looks like. That's an x-ray I took of a ballerina. That's what the foot looks like when a woman or a man is a ballerina standing on point. So that brings up a couple questions. What is preventing this dancer's ankle from falling apart? Because she's got all that weight pressing down. Why doesn't it spread apart and collapse? What is providing the dancer's ankle the ability to come up onto point? So you have two things. She's pressing down, but pulling up. How is she doing that? Is that even physically possible? So what do we have to say? If it can't be muscle, we just proved that muscles aren't strong enough. And it can't be bone because you know that bones will not hold together with any kind of pressure without ligament. And we just said that ligaments aren't strong enough to do it. So what is keeping this person on point? The answer, it must be biotensegrity. Meaning what? We will see. Tensegrity was originally thought of or documented by a man named Buckminster Fuller. And he lived between 1885 and 1983. And you can see on your left, or that would be your right, a dome. Now, when somebody walks on that dome, the pressure when you're on one part of the dome or the other part of the dome are all equal. It's like that truck going across the bridge. The pressure and the weight is spread out throughout the entire dome. Now, you see the same structure in nature. You have the Buckminster Fullerene, which is a carbon-60 molecule, and it has the exact same structure as tensegrity. And you see Buckminster Fuller made a 3-wheel car, which we no longer keep. So what is tensegrity? Tensegrity, by definition, is tension and compression are in all segments causing an integration of the unit, integrity. It keeps it together. So tension and compression are all working together, this thing does not work. You want to get it? You want to be my granddaughter? You want to be my granddaughter? Jonathan, you got somebody taking over. Okay, so tension is continuously transmitted across all members. So when this person stands on point, what's pulling her up? Everything, her neck, her shoulders, her back, her leg, everything is working in unison to bring her up on point. What's preventing her from falling down? Everything. All the tension element and the compression elements are bringing her to stand straight. When you go by a building under construction, you're going to see exactly the same thing. And you no longer will just look at, oh, that's a nice building. You're going to look at the tension and the compression elements and try to understand what the engineers put together. So Biotensegrity was made by a friend of Bjorn and mine, Steve Levin. Do you know if Steve is still alive? Huh? Okay. Oh, Steve Levin, a physician in Washington, D.C., came up with the concept of biotensegrity. And Steve said, structure and movement stability of a living body depends on the balance of soft tissue. The flexible soft tissue helps to distribute the load across the entire body. So your muscle, your ligaments, your fascia transmit the issue or the strength back to the bone. So everything is working together. And if there's a failure in one part, there's going to be a failure in the entire structure. A biological system where tension is applied by soft tissue, muscle, and fascia to compress a rigid member, a bone, around the joint so that bones do not touch each other, but form an integrated system for the distribution of load and allows for easy movement. Think of it. You would think if I'm standing that my femur should be resting on my tibia. I'm compressing it. It should be thing. But when you can go into a joint and aspirate it. How do you do that? The joint should be separated, should be together, but it's not. You can get into any joint if you have a fine enough needle. Why? Because of tensegrity. The soft tissue is stabilizing the joint so the joint doesn't have to work. Where is arthritis? When you lose that tensegrity and my bones start misforming or my joint misforming and I keep putting pressure on the soft tissue or the hyaline cartilage, which you know is very soft, is going to wear out, and then I'm going to have bone on bone. Then what does Mother Nature do? She brings osteoclast, and all of a sudden I have all these nodes in my finger and my knee and my back. Why? Because I've lost tensegrity. Okay, as a physician, all of you always ask yourself, why do muscles become weak and strained? Why does it first come in with a strained leg muscle? You've all seen it. Or shoulder girdle that's not working real well. Or a backache or a neck ache. Okay, why do we become old and bent and strength? How is that possible? Where did that happen? And why do joints become sublux? Why do joints come out of joint? They don't completely out of joint. They're not really aligned perpendicularly. And why do ligaments become stretched and torn? How do I become loose as a goose? Okay, so what is tensegrity and what do ligaments and prolotherapy have to do with us? Why do I care? You came into me with a backache. Here's a pill. Go home. Rest. Here's a note. Don't go to work for 3-4 days. And you're good. Goodbye. You know, I'm going to disown you soon. Okay, thank you. Thank you very much. So anyway, we need to understand tensegrity, and we need to understand how do we work with tensegrity in order to reposition the joint and the muscle that they will work together. So if you think of tensegrity, which to me is a triangle, you have your joint, you have your bones, your muscle, and your ligaments and tendons, in my opinion, are all the same. When all the parts work together, we have stability. When one of the parts is broken, then we have instability. And instability causes pain, dysfunction, problems. And this is in your heart, this is in your stomach, this is in your eyes, this is in your knees, this is in your back, this is all over. Tensegrity is like molasses or water. It covers everything. If I increase tension in any segment, it causes tension to increase in other segments. So let's say I have a spastic low back. So what happens? Everything on that side is going to be tense. My hamstrings are going to be tense, my shoulder, my neck, everything is going, when I increase tension in one part, I increase the tension in the other part. And by increasing compression in any segment, causes compression on the other one. So I'm compressing my hip joint. Why? Because I'm bringing it together. Why are tensegrity structures economical? Tensegrity examples. This is in Bluefield, West Virginia. This is the gym, and it's a huge, huge place. And when you go to the airport, I want you to look at the roof of the airport. That is tensegrity. And you look at the beams I was pointing out to Jonathan. You have all these tension elements holding that roof up. The roof weighs tons, and yet it doesn't collapse. Why doesn't it collapse? It has no, you can see it's just wide open. Why doesn't it collapse? Because you have tensegrity. You have tension elements transmitting the weight of the dome to the structure, the bones on the side. You see this, the hexagonal, in viruses and cells. They all follow the same pattern. Nothing is different. And finally, of course, my favorite guy, the giraffe. Have any of you ever been next to a giraffe? They're huge. You know, we were in a park in Florida, and they have this cage 20 feet high. And you go up there, and the giraffe looks at you and expects you to feed it. And I go, I don't know. You know, but the giraffe, when you look, and if you look at a duck flying, or a goose flying, a swan flying, where's its head? Its head way out there. How is that possible? What's holding that head straight? It's called tensegrity. You know, the bones and the muscles and the ligament all working together so that this swan can have this beautiful shape as it flies and flaps its wing. So it's got to keep its head up, it's got to flap its wing, and it's got to keep away from the other birds. And this is a tensegrity model that everybody should have in their office. They're easy to get. I've been trying to make one, so I ended up buying one, and it's in my room. I'll bring it tomorrow, and maybe we can put it together. And now, This is something we see all the time. So let me ask you a question. How is this possible? You have a combined weight up there of what? 200 kilograms, maybe? What? Sorry? Okay, so go ahead, next slide. So what's holding it up are the spokes of the wheel. This little thin wheel is taking whatever the weight is on the bottom and putting it around the entire wheel. Oh my God, tensegrity model. And no matter what way I move it, thank you. Whichever way you're adopted again. You're in the wheel. And you can see it doesn't matter what I do. Thank you. Most wonderful thing. So think of this picture as understanding tensegrity. All of that weight is being pushed to the little part of the wheel, and the wheel doesn't collapse. How does that happen? Tensegrity. Why do I care about that? Do you have patients? I'm sure you do. Who have multiple muscle complaints. Oh, my neck hurts me, my hip hurts me, my knee hurts me. Oh my God. In Yiddish or German, we call them kvetches. And I would say to my nurse, what's wrong? And she would say, oh, he's a kvetch. Okay, fine. Okay? When you take care of one part, I just took care of the shoulder. Oh, but now my back hurts me. Another example, you go to the dentist. He fills one tooth. Oh boy, I feel that. But now this tooth hurts. Interchange. And when you resolve one problem, oh, my foot feels better, my back feels better. Oh, my hip feels better. How did I do that? I only took care of one part of your foot. How did I get your back better? Is their pain dependent on what they're doing? Sitting, standing, running, lifting, jumping? What is their pain pattern? Go ahead. We have 206 compression elements in our body. We may have more, but that's what the anatomist tells us. They stabilize by the pull of our tension elements that are what? Muscles, tendons, ligament, and joint capsule. In another lecture, we're going to explore what does a ligament and joint capsule do and what are they. All connective tissue. This is so important. All connective tissue come from mesenchymal tissue. That will be the clue to how you're going to repair the problem. Mesenchymal tissue. The embryo. So important. The most boring subject I had in school was embryology. Oh, I could never get all those parts together. Plus it was at 8 o'clock in the morning. So ligament, muscles, and bone, they stabilize each other through tensegrity. They have the ability to synthesize complex molecular structures. They take wherever you're at, and they bring it together harmoniously. Okay, now we're going to talk a little off point. What about pain? All of us, why am I here? I'm here because my back hurts me, my knee hurts me. Otherwise, I'm not coming to see you. You know, you're going to hurt me. I'm not coming. So let's talk about types of nerve receptors. We have mechanical, we have chemical, and we have thermal. Those are the three types of basic. There are really many more. But basically, you have mechanical, chemical, and thermal. When I heat up the body by rubbing it, I bring healing, right? Chemical, I put a drop of something on my skin. I can either heal it or not. Mechanical, I hit something that hurts. Okay, the nerves, all of them, have a very rich supply of afferent nerve bundles. That means they go back from the limb to the central core. All of them. Now remember, pain travels at 20 millimeters per millisecond. Reflexes travels at 200 millimeters per millisecond. The way you prove it, turn on your stove. Put your hand next to the heat. You'll pull it away long before you feel the heat. Or when you stick a needle in. Oh, now it hurts. Okay. So how can I use tensegrity? Maybe the pain is coming from someplace else. Maybe that hip pain really isn't hip pain. Bjorn did his examination, and he said, oh, this ligament is strong, that ligament is strong, this muscle is good, that muscle is good. So why does my hip hurt me? So maybe the pain is being transmitted from one place to another place, and your perception of it is in your hip. But that's not the initiator of the pain. The pain is in the knee, in the foot, the ankle, the neck. Could be someplace else. When my feet hurt, how many of you have heard this? I heard this all my life. When my feet hurt me, I hurt all over. I can't stand. Why? Because the feet pain will transmit to the neck pain. The neck pain will transmit to the foot pain. It's all the same. Your job is to find out what is the embryo of the pain. Where does the pain really come from? That's not so easy. So let's go back to Lenny's law. I come in with a neck pain. You do prolo, you do physical therapy, you do medicine. I still have my back. It doesn't work, but it worked on my other patient. Why doesn't it work on you? Maybe you should look someplace else. Maybe the pain is not coming from the neck, but it's coming from the knee. Thank you all. Thank you. Any questions? And if it's about biotensegrity, I don't think I can answer it. But go ahead. Everybody knows it well. Yes, dear. Dini.
And I want to, I'm always amazing with biotensegrity concept, and it helped me a lot from my daily practice. I just want to ask you, when you treat like this part, do you treat all the fascia, ligament, and muscle in one injection, or you try to make this one? Oh, I know this is from ligament, so I treat it first. Or do you treat it all in one session?
Very good question. And I will tell you that I have matured from 40 years. I now have a different opinion, totally different. Before, if you had asked me 10 years ago what I would do, I said, well, I would just treat the ligament. The heck with physical therapists. They never get anything better. The parts of it come back, so I'm not going to send you to physical therapy. You go to the chiropractor, you're good till you get up and walk around, and then you're back again. You know, maybe you're crazy. You need a psychiatrist. So I would always treat the ligaments, in the joint capsule and try to get things in alignment, and then I'll tell you another part of it. And I had pretty good results. But as time has grown, and I've thought about it, and I'm now doing exercise, which I never did before. That was a pain in the neck. I hate exercise. But now that I'm doing, I really feel better. I'm standing straighter. My back doesn't hurt me anymore without prolotherapy. So maybe I should have gotten more involved with the physical therapy. So I think it's really an integrated thing. And we will talk later about hormones and all of that. There's no one magic bullet. You have to look at the person. That's what's in front of you. It's not an arm, not a leg, not a back. It's a person who's in front of you. They could be having emotional problems at home. He and her are not getting along. The kids are driving us crazy. You know, I used to love you. I hate you now. Where do I take all of that emotion out at? In my back or my foot? There's a whole philosophy that if you can't make a move, if you can't move from one spot to another, you're going to have hip pain. If you can't stand the tension, you're going to have foot pain. So that is an old concept. So yes, I treat now, if I was in practice, I would be more holistic. I wasn't then. Thank you.
Thank you. I think it's same. Yeah, day by day I learn and try to make it. You are very correct.
Thank you.
Thank
每
you.
天的临床上，我发现你说的是对的，谢谢你。
You understand that I'm hard of hearing, so consequently,
你知道我是听力是很有困难的。
Thank you, Danny. I was curious about the sample that you bring in the very last. For the neck pain, you might think of treating in the knee. So,
Right.
So how is there a systemic approach to evaluate the holistic biotensicity by finding the treatment spot?
Okay.
怎么样用
That's a-
这个
this
标准对的
question
概念
seems
整
to
体的
be
去找到它
very
核心的问题是什么？
So a person comes in with neck pain or back pain. How do I find out where the problem is? There is a chemical that you all have, and it's very inexpensive, and it's called lidocaine. Lidocaine stops afferent and efferent nerve transmission by breaking up the chemical railway of the nerve. When I don't have that nerve input, if I numb that part of the body, and then I say, okay, come back tomorrow in 2 or 3 days and keep notes and tell me, how does this feel? Oh, doc, after that injection, my back felt much, much better. Oh, maybe that's the issue. And then the other way I do it is, you all know what the forward bend test is? Who does not know what the forward bend test is? You all know what it is, I assume. There's another forward bend test. So I do a forward bend test when I'm standing. Then I have them sit.
我叫他们坐
And
下
I do
来
a，forward bend
再
test.
做一次往前弯的测试，
And
让
I see what happens.
我们看发生什
Why?
么事情。
When I'm
为什么要这样
standing,
做？
I'm compensating, and I
因
know
为在
what's
站在
happening
站
to
的时候，
the SI joint.
我
When
会比
I'm
较
sitting and I
SI
bend
状的两边
forward,
的变化。
now I know what's happening to the thoracic and above.
如果做的往前，
I've taken the foot or the whole lower extremity out of the equation, and I can see where some of the pathology may be. Not positive, but it's a quick way of learning. Forward bend standing, whoops. Forward bend sitting, nothing. Oh, so that means it's from the hip or the sacroiliac to the foot, any one of those. It's straight when you're standing, but when you're sitting, it's up. That means what? I'm having some thoracic, neck, or shoulder problem that is changing the thing. So that's an excellent question. Thank you. Any other question? Okay, so then let's take a break. Everybody stand, walk around, get the blood flowing again. Come on. Good. Okay. Okay, the next one.
开了，测试。翻译开了，我开了，翻译开了。喂，测试中，听得到吗？喂，听得到吗？然后要关吗？Hello，一直在讲话，有在讲，有在讲话，继续讲，听得到吗？诶，好，中场休息15分钟，
听得到
吗？
听得到。
目前3个路都有声音，还没有区分。
喂，都有。
还要讲吗？
差不多哎，因为没有什么内容，它都是听到声音吗？这个原始音讯有。好，那翻译我们讲一下话可以吗？还是阿强你讲？对，用翻译的讲。
好，现在示范。现在翻译我的那个线上也都有声音。喂，1、2、3。
阿强，你试看看。
1、2、3。1、2、3。1、2、3。1、2、3。1、2、3。1、2、3。1、2、3。1、2、3。1。
你可以帮我加一下吗？你有加了吗？有，我进来了。喂喂喂喂，英文可以。没有，我关掉，现在是只有。喂喂喂，你现在有指定我翻译的功能？有啊，就是直接全部送出去。我们现在换一个账号，还是你们学会有账号之类的？我用你的账号登录。你现在我觉得这个不是我现在可能不是以翻译功能进去。对啊，我现在没有翻译权限。因为我现在翻译我并没有翻译权限，我只是一般加入的。有，我来试。1、2、3，对啊，所以是那边设定的问题。对啊，这样就好了。是不是刚刚我并没有翻译的权限？这样应该就可以了。好，我现在是现在是现场英文。Hello， 有听到吗？我现在问我同事有吗？现在是原文，现在是原文哦。现在是现场声音测试。同时现在是现场声音测试，现场声音测试。现在是现场声音，那你选现场声音。现在是现场声音。可以，1、2、3，现在是现场声音。现在是现场声音。现在是现场声音。Hello，可以。嘿，1、2、3，喂，嘿。1、2、3。 不要变薄就不好，不然变形。然后我这张线不要变，不要有变形。再一个东西，这样变变。可以吗？可以吗？那我要接送上去了，但是我被扯掉了，不要，后死了，后死了。
嘿嘿，
现在中间有
嘿嘿，
那现在这个是哦，那你帮我把它封住，再做最后一个，我卖了。我们做最后一个都可以都可以。
现在是现场声音。
好，你同意你可以选择。
继续讲，同意了可以继续讲。对，你继续讲，你一直讲，我现在是现场，现在是现场声音，所以你选口译应该就没有现场声音了吧？现在是现场。
Okay. I sincerely apologize again for the online audience. For there was some problem, technical problem with the simultaneous translation, and now it's fixed. Okay. Okay. So in Taiwan, we don't have a podiatry department if you go to a hospital. So it's really a precious experience to learn from a podiatrist, from especially who is a very experienced and endeavored himself to pain management and prolotherapy. And so let's welcome our second session by Dr. Leonard Howitz. Thank you.
You, Jonathan. It's number 2. It is number 2. Good. Okay. Okay. Now, most of our specialties for us here, at least for Bjorn and I, are, excuse me for sitting down, please, are ligaments. Now, I want to go into the very essence of what a ligament is, or are. Okay? What are ligaments? First of all, like I told you before, a most important thing to keep in mind, where do they come from? And so we have the embryonic thing. We have 3 levels of embryo. In the 3rd week of the fetus, you first have the endoderm, the mesoderm, and the ectoderm. And what I find that each one of the embryonic tissue is all of that embryonic tissue actually work like its beginning. So if I have ectoderm, skin, etc., all of it will have the same way of being treated, same way of being healed. If I have endoderm, I will approach it with that in mind. What is the basic concept of the endoderm? The mesoderm, which I'm interested in, and I hope you are interested in, has its own specific embryonic tissue, and that becomes so important. So the tissue that arises from the mesoderm are 1, skin, heart, bone, muscle, and tendon, what we're interested in, blood and urogenital system. All of that is mesodermal. Meso meaning middle, the mesoderm. And this is supposedly what the embryo looks like. They all have mesodermal origin. Excuse me, go ahead. And what's the essence of the mesoderm? Fibroblast. Fibroblast. So when you know that, and the ligaments have a lower collagen but higher water and proteoglycin, and low viscosity and cellularity, when you look at a ligament, you don't see under the microscope, you don't see many cells. You see a lot of fiber, but no cells. And the capsule and the tendon bind together to make the musculoskeletal system. They are extremely strong and in resisting tensile movement. That means they go sideways. You can put them under a lot of stretch, but they tend to shorten with age. I was just telling, in the thing, I used to be 6'3". I'm now 5'5". No, I'm really 5'7" and a quarter. But now I'm only 5'5", maybe. Anyway, when did I get so short? And all of you are also going to get shorter. That's called gravity. Now, the capsule and the tendon bind together into a musculoskeletal system. They're extremely strong, but tend to shorten with age. How do they insert into bone? They insert into bone or the periosteum by Sharpie fibers. These are small fibers that you can see. And all of this, although you say, well, I learned this in school, all of this will now start playing a part in how you're going to treat. So all ligaments, tendons, muscles, and bones are mesenchymal. Please, please try to remember that. There are three types of mesenchymal tissue. Soft to hard, meaning muscle, ligament, and bone. But there's another kind of mesenchymal tissue. And that's hard to soft. That's bone to ligament to muscle. It's all the same. There is no difference in my mind between any of it. They all function the same. And I think that's something that it takes a long time to say, oh, well, muscles are soft, bones are hard. No, no, no. They're all the same tissue. Now, you have two tissues. You have ligaments and you have joint capsule. They're almost the same, but they're different, a lot different. So the joint capsule surrounds the joint. It's made up of areolar tissue. That means it's really soft, got a lot of holes in it, microscopically, as opposed to ligaments that are stronger. And when you look on the microscope, you'll see here's the joint capsule. Oh, here's some tight fibers in the joint capsule. And we're going to call that ligament. Are ligaments and capsule different? No. If you remember from when you were in school, which was a million years ago, they talked about doing gut revision. And they took the stomach, or they took tissue from the gas from the intestine, they made it into the stomach, and all of a sudden it lost all its cilia. You remember that? I think there were two surgeries, number one and number two. Neither of them worked. But anyway, one of the things I remember in pathology, that when they changed the environment of the tissue changed. Remember that. To me, that when I heard it, it was really amazing, and maybe that was the beginning of my journey. So in the ligaments, we have three kinds of ligament. We have intra-articular ligament. Give me an intra-articular ligament. The ACL, fantastic. Okay, we have an intrinsic ligament. Give me an intrinsic ligament. The deltoid. We'll call that, because I'm more familiar with the foot than I am with the shoulder. And we have extrinsic ligaments. Give me an extrinsic ligament. You see it in the knee. Okay, right, exactly correct. Thank you. So you see there are three different types of ligament. But when you look at them under the microscope, they all have similarities. They have very few cellular tissue. They're very stringy, if you will, and they have a large tensile strength. So there are similarities functionally different. Ligaments are based on their relationship to the joint capsule, either inside the joint capsule, in the joint capsule, or outside of the joint capsule. But they're still ligaments, and we're going to treat them all the same. Okay, ligaments, tendons, and capsule. All of them are made up of what? Collagen, fiber, fibrochondrocyte cells, and fibroblasts. So all of our treatment are going to be geared to the mesenchymal origin of this tissue. And you have pre-bone. That means, remember I told you that we have soft tissue and hard tissue? Well, what we find, and I'm going to show you in the next slide, how all of this progresses. It's all the same. They're all layered. And the bones are a little bit different, even though it had fibroblasts, but the fibroblast has now changed to become osteoblast. Different things, same fiber, but different names. Who gave them the name? We gave them the name. Is that their name? I don't know. They work the same, but we gave them the name. You know, like you have a name, you have a name, you have a name. Are you really any different? Not really. We all are the same. Okay, so here is a schematic. Zone 1, you have tendons and ligaments. Zone 2, it starts getting a little bit harder. And then zone 3, we start seeing calcium integration. And number 4, all we see is calcium. But it's all the same. Okay, all the same. Tendons are aligned on the long axis of the body. Tendons are always aligned on the long axis. That's why you and I stand straight. If we were a cow, it would be on the horizontal line and some other thing. But if you could take the cow on its feet, then it'd all be on the longitudinal line. Their role is to transmit the muscle. So the muscle is the engine, and the transmitter, the train, is the tendon, and the cellular alignment allows for the transmission of all the forces to the bone. So we don't have a pulley system. We have a transmission system. We're transmitting one power to another power to another power. Excuse me. So that's important to keep in mind when people start talking to you about pulleys and axes and all that, especially in the shoulder and in the elbow. They're going to talk to you about that, and I'll show it how it works in the foot. Anyway, so all of this is where the muscle transmits its energy to the tendon. The tendon, based on tensegrity, keeps the joints together with the joint capsule, and therefore we can do what we do. Okay, we have 900 ligaments and still counting. You know, they came up with a number. I don't know. Ligaments are made up of 80% collagen. The ligament consists of dense connective tissue with parallel fibers, so it doesn't matter if it's extrinsic, intrinsic, or intra-articular. Under the microscope, they basically look the same. Some ligaments are rich in collagen fibers, which make them more sturdy and elastic, and which allows for movement. And others of them are more difficult to move, so they hold for stability. But the most important thing to remember is they have very, very poor blood supply. No blood, no healing. No healing, no function. So blood is an important part to everything that we do, because the blood holds all the essence. And the Bible said because blood is the essence of man, and that is true. Okay, the joint capsule, which is the same mesodermal tissue but modified, has two components. You have basically two layers. Like clothing, you have two layers. You have the inner layer, which secretes fluid into the joint. You have the outer layer that gives us some stability and joint integrity. And I will tell you that what I would do using the fluoroscope, which a lot of times people come, especially with an ankle injury, and you don't know if you're treating an ankle or joint capsule. So under fluoroscope, I would inject fluid radiopaque fluid into the joint and see if it leaked. And if it leaked, I could see, one, where is it leaking? And then I would know where the damage was done. And then I would go right to that spot and treat that spot, and not the ligament, just the joint capsule. And that helped a lot. But I was very fortunate. I lived in a very small city. I was close friends with the radiologist, and all I would do is say, Steve, what are you doing for lunch? Oh, I'm coming over and I'm bringing a patient. You know, and he didn't charge anything to the patient, I don't think. And it was covered by their insurance. And the patient didn't know what the hell I was doing, but I was doing it because I wanted to learn what was going on. To me, all of life is a learning process. It's up to me to figure out what am I learning. Don't always know. Okay. So the joint capsule has what? Mechanoreceptors. That's part of the nerve. It tells the joint, or it tells the brain where the joint is, subluxation, the chiropractor putting the joint back into place. The free ending tells the joint where it is. If it's out, you get things like, if you ever dislocated your jaw, you go, oh, that hurts. Put it back in. Oh, that feels better. You know, or your shoulder, your finger. You know, consequently, so it lubricates the joint. It restricts the joint movement. And by restricting joint movement, it stabilizes the joint. Connective tissue innervation. The spinal reflex arc innervates the muscle tone. All muscle tone comes from the nerves. The nerve is the brains, if you will, of what we're doing. How do you know that? Anesthetize it. Sit and say, move your foot. At one time, I was doing a knee, and I kind of hit the perineal nerve as it wraps itself around the fibula head, and the woman goes to stand up and falls. I can tell you, anesthesia works great. Okay. Nerves also supply the joint capsule, and they also innervate the antagonistic muscle. The antagonistic muscle always works against the other muscle. So when you are doing weight training, what muscle do you want to train? You want to do your biceps or your triceps? If you want to do your back muscle or your abdominal muscles? You want to treat your antagonistic muscle, because when that's strong, the other muscle will also be strong. Okay, and muscle tension causes a reflex, okay? When my feet hurt, I hurt all over. How many times did I hear that? You may not hear it, but I heard it, because that's what I treated with feet. You know, they said if the world was a nail and I was a hammer, all I would do was see the nail. You know, and that's what happens to all of us. We have tunnel vision. We know that. And there's nothing else in the world except that. That's all I know. I don't know anything else. And I used to say, people say, what do you specialize? I said, I specialize in the little toe or the left foot. I know nothing about the toe, the right little toe. Really, that's all I know. Okay. The nerve, okay. Something, we're having a mechanical difficulty. And then there's a thing called substance P. And when they first discovered it, I said, I can't see it, therefore it doesn't exist. Well, now they figured out that yes, it really exists, no matter what I said. So pain is such a complex issue. One of the things I treated a lot was what we call reflex sympathetic dystrophy, RSD. It's had about 11 names. I think they now call it regional pain syndrome. And that gives you a window into the pain mechanism, almost impossible to treat. But one of the things I would suggest doing is, if you have people with RSD or this regional pain syndrome, treat the mechanics. It may not help, but at least it's a try. Okay? Are we on?
I think we're on. Next slide. Yeah.
Okay. We already spoke about that. This is what Bjorn mentioned, and it's so important. When you're treating ligament, the break in the ligament seems, for the most part, to happen at the bone joint junction. So if when you're doing your prolo, you're not touching bone, I don't know where you're at, but you're not where you're supposed to be. So I would suggest that when you touch bone, then you know you're there. Now, the other part that came to mind is, am I really doing anything with my solution? Or is my needle touching the bone causing bone reaction, or the fibroblastic reaction, that is really healing it? You'll have to talk to Bjorn, because he did some of the original research on this, which we'll talk about. But anyway, when you treat ligaments, you really want to be on bone. You want that needle to be proximal to bone, no matter what you're doing. Okay? There are 3 types of sprains, and I assume that they go to all parts of the body. You have a mild sprain, and that should heal in about a few weeks. You have a grade 2 sprain and that should heal in 6 to 12 weeks. And then you have a complete heal that heals in 3 to 4 months. That's what the books say. I don't agree with that, because you see people never getting better. I just twisted my ankle. I moved my shoulder. I hit my back. I had a mild sprain. Go home. Take a few non-steroidals. Here's some pain pills. Here's a couple weeks off of work with pay. And you'll be back. You'll be fine. And they come in and they're not fine. Okay, what's really going on? So I don't agree with this model. Yes, some people, maybe most people, get better, but not everybody. Ligaments and tendons heal with scar tissue. So important to remember. And why? Because scar tissue has no strength. Scar tissue has no strength whatsoever. And you can see the same scar tissue, by the way, in your skin. And if you have a scar in your skin, try to stretch it. It doesn't stretch. It doesn't move. It gets adherent to the tissue below it, and you have your problem. And then that will go to my philosophy of what is fascia and how does fascia work. In my opinion, we have afferent fascia and efferent fascia. And if you ever, and I'm sure you all have, if you ever gone into the woods and you see a stream, water going by, and then you have a couple stones in it, what do you see happening? The water gets confused. So when the surgeon, which I was for 10 years, make the cut. Do I care about the fascia? Nah. Cut them high, cut them wide, and cut them fancy. Bone tissue heals from side to side and not from end to end. Remember that? All of you who had a surgical internship learned that. Cut it high and cut it wide so you can see what you're doing. Then you sew it together. You put the afferent and the efferent fascia together. What do you have? Confusion. That's why neuroprolotherapy becomes so very important. Okay, the next thing you have to know why people don't heal is they have hormonal imbalances. And hormones become very important. Now, you have to know that women has testosterone. And men has estrogen. Oh, they didn't teach me that in school. They told me women have estrogen and men have testosterone. Wrong. We have a mixture of both. And when you have an imbalance in your hormonal levels, then you have non-healing. So one of the things you want to do in your treatment is to find out, and you can do that through a blood test, expensive, what is the percentages of estrogen versus testosterone. The problem you have with that is called the bell curve. How do we know that you're supposed to have X amount of red blood cells versus white blood cells? But what they did is they took 100 people. You feel good? Great. You feel good? No, not so good. You feel good? I feel okay. And then they took your 3 bloods and they took the bell curve. Oh, you felt good? Your red cells were here. You felt bad? Your red cells here. Ah, what is the middle? Is that true? No, it's the bell curve. It doesn't mean anything. So one of the things, like I had a professor in school, Dr. Benoit, who we were all afraid of. If you ever had a professor that you're afraid of, he was the one who was big, tough, rough, and whatever. And he said, if a patient comes in and all of your tests are normal, but the patient looks sick, you know what? The patient is sick. It doesn't matter what the blood test tells you, okay, or what the MRI tells you, or what the X-ray tells you. You know, MRIs are slices. So it missed a slice. The pathology with another slice. Ultrasound? No, I cannot figure out ultrasound at all. I've tried, but it doesn't go. I'm too damn old for that. You know, MRI, it's nice to know. I would do always a bone phase. Why? Because I want to see where the most uptake is, and that tells me where the pathology might be, and that's what I would do. I didn't count on the MRI. So when our muscle defenses fail, then the ligament, which are next in line, are also going to fail. What also causes it? As we get older, our ability to produce fibroblasts are reduced, period. And it doesn't matter. You can't get a pill. You can't get an injection for fibroblasts. When it's gone, it's gone. It's like my hair. It's gone. It ain't coming back, period. Lack of exercise. Exercise is good. Why? Because it tears the muscle. When it tears the muscle, what does the muscle do? It brings in fibroblasts that does the healing, that makes you stronger. So exercise is good only because it, one, it's pain in the neck, and number 2, it tears muscle. Smoking reduces your oxygen level, introduces carcinogens. What else it does? Beyond me. They found so many different things in tobacco. Plus, they're now adding things to tobacco. So all of you who are vaping, understand you're taking poison into your body, no matter what you think you're doing. Immobilization. You ever see a person in a cast, when they come out of the cast, their limb looks shriveled. They didn't use the muscle. You don't use it, you lose it. Non-steroidal. Big problem, because non-steroidals reduces the amount of the ability of the body to bring in healing factors. Do I take them? You darn right I do. I take them every day. Do I care? No. Compromised immune system. We all know that. And endocrine imbalances. And that could be your thyroid. That could be almost anything. So when you see your patient, you're not seeing a patient. You're seeing a person. Look at that person. Okay? Now, 3 stages of healing. Stage 1, hemorrhage, blood. That is what's needed in order to bring all the healing factors in. 2, after you get the healing, you have proliferation. The body starts doing its chemistry, and the body starts healing. And finally, remodeling and maturation. Why am I bringing this up? Because when you're doing prolotherapy, or any regenerative medicine, I don't care if you're using blood, if you're using saline, if you're using glucose, whatever you're using, the body's going to do the same thing. So you have to spread your healing, your treatment out, so that you hit this thing when it's almost healed, but not completely healed, to keep the healing process going. So people who see patients today, tomorrow, the next day, and give them a shot each every day, they're doing nothing. If I see you this week and I wait 2 weeks and your healing is just getting to another stage and I reintroduce the injury, I'm reintroducing the healing process. So I just keep extending it. Okay. How do we heal? We heal by mesenchymal stem cells. Very important. Everything is mesenchymal. And we can do whole blood. They do that, by the way, in Russia. And it's cheap. You can use dextrose, inexpensive. Protein-rich plasma, PRP. I didn't have good results with that. And that's just bringing in the factors of the blood in the dextrose. TGF, which Bjorn is working on, I think. Am I right, Bjorn? Yeah, Bjorn is working on that. Interleukin 10, which I don't even know what that is, but it was in the book, so I figured it was true. But what I used most was blood and dextrose. Those were my 2 go-to area, especially for tearing Achilles. The best treatment I found was whole blood. Dextrose proliferant, we don't know exactly what it does, but we think what it does is stimulate fibroblastic reaction. And they use as little as 10%. I never used 10%. I was probably wrong, but I used a much stronger solution. And I'll explain why when we get to that part. It's been done for over 100 years. 1933 or 32 was when I think George Hackett started to do it, but it has been wonderful. And they've added phenol, zinc, glycerin. I added nothing to it. I never found that it was necessary. I always found that time did it, and I didn't want to go. For a while there, they were using phenol, the Angli solution. I don't know, maybe Bjorn still uses it. And I used to say to Tom Raven and others, can you imagine going to court with a patient who had a bad reaction? You hit a nerve in the back, And the lawyer says to you, tell me, doctor, what did you use? Oh, I used phenol. He takes a goldfish. He drops in a jar of phenol. What do you think's going to happen to that fish? It's going to be good for the fish. And then you have a jury looking at you. Not a good idea. So that's one of the reasons, because in America, we're very litigious. If something doesn't go right, it's not my fault that it didn't go right. It's you, the doctor, didn't go right. Why was my wife fighting me? It's your fault. Why did I lose my job? It's your fault. Oh, my cousin is a lawyer, and the only way he's going to make money is if he wins the case or the insurance company pays him. I don't know if it works in your country that way, but in America, everybody has a cousin who's a lawyer, and the only way they make money is by chasing ambulances with the doctor being the prime target. So you want to do whatever you can do to mitigate that issue. That was my feeling living in America. Okay, vitamins. Do I believe in vitamins? For a long time, I thought that was the most expensive urine you could get. But I've since changed my mind. Thinking men think. Thinking men change their mind. I'm a thinking man. I've changed my mind. Omega-3, magnesium is so important. Vitamin D2, zinc, vitamin A and C, and I've added magnesium to the whole equation. Physical way of doing it, you can inject mesenchymal cells. You can use interleukin-2, autologous blood stem cell, and I like dextrose. Why? Because dextrose is inexpensive. What makes feeling not good? Age, smoking, alcohol, non-steroidal, Ehlers-Danlos syndrome. And I have to tell you about Ehlers-Danlos. We think of it as being, a real thing. My grandson tells me he's double jointed. Is he really double jointed? No, he doesn't have two joints. He has very loose ligaments. What's going to happen as he gets older? Back pain, knee pain. What do I tell him to do? Exercise. Get the core muscles going. There is no such thing of double jointed. Congratulations. That's not what you got. Next, vascular disease. Bjorn will tell you about vascular disease. No blood, no healing. Malnutrition, no protein. High carbohydrate diet. I'm now a borderline diabetic. I don't know what that means. So I've reduced my carbohydrate intake. I just read an article because I'm really fascinated with it, that high carbohydrate diets, let's say sugar, will cause you to have memory loss. So I have enough trouble with my memory as it is. Eating more sugar, more carbohydrates is not going to make me any smarter. Low protein diets, we have a lot of people here who are vegetarians. And if they don't get protein like from beans, they're in big, big trouble. And vitamin deficiencies, if you remember beriberi, any of you remember beriberi from school? I don't think any of us scurvy. Has anybody even seen a case of scurvy? No, but you know about it. Low vitamins, right? Okay. What we're doing, what we know from our research, is that early mobilization is critical. So when you do your prolotherapy, whatever you use, see that they should start using that limb almost immediately. Resting is not good. Reduce abnormal adhesions. So what you'll see, at least I saw, that a lot of operations, which is an easy solution for a lot of problems and expensive, cause scar tissue. If you don't break up the scar tissue, you've done nothing. You've got to break the scar tissue. The easiest way to use it is a 30 gauge needle, lidocaine, and or water, saline, and you go into the scar and you reduce the scar. You want to have your exercise based upon the way the body moves. So this cross training, I don't know. Okay. Any questions? Yes, sir. It's a pain, isn't it?
Yes. Thank you, Dr. Lenny, for the interesting lecture. My question is, I've read that the use of hyaluronic acid. I want to ask your opinion about the role of hyaluronic acid in the tendon healing and biointegrity. Thank you.
I don't think I understand the question.
My question is the use of
hyaluronic acid.
Yes.
Oh,
yes. Thank you.
I never used it because it was too expensive and I'm basically cheap. But hyaluronic acid, which was really big back in the 70s, that's 1970, that was a few years ago, 1980, is that it actually helps spread the tissue. That's why when Dr. Eck was speaking about using DSMO, where that works, it opens up the blood vessels. That's what I think it does. More than that, I can't answer you because I have no real experience with it. But I found for myself, just keeping it simple was more than enough. The body will heal without all of your help and spending all that money. You're not going to get paid any more by using DSMO or hyaluronic acid. Use your glucose, at least for me. Use your glucose. Give it time. You'll get better. Don't spend the money. You got children? Give the money to your children. Okay, any other questions? Yes, Tina.
I just want to ask about the omega-3. Omega-3.
Oh, yeah.
Omega-3 is, I know it's anti-inflammatory, but there's a statement that omega-3 will decrease the cortisol.
Okay.
But many patients,
Cortisol or cortisone?
cortisol.
Cortisol is not cortisone.
Cortisol.
Yeah, cortisol.
Yes.
You need cortisol
Yes.
in order to do it. But cortisol gives you, from what I understand, is an energy producer.
Yes.
It is not an anti-inflammatory.
Yes, but there's many patients that I found that low cortisol, it related to the hormone actually, and it will cause more ligament injury. But omega-3 is sometimes we need it for pro-inflammatory. And how about your thinking about this? Can we give omega-3 for low cortisol, because the cortisol actually lower than normal? So it's like a circle. I found many patients that feel like a circle of cortisol, but actually it's lower than the normal cortisol. If I get to give omega-3, is it helpful
Right.
at the time or not?
The problem you have, I can only speak from my experience, is that your license, if you have a general license, you can prescribe estrogen, androgen. You can do anything you want. If you have limited license and you start messing around in somebody else's area, the endocrinologist area, they really get upset. The problem I have is that most of them do not understand the entire situation. I had a lady come to me, a very pretty woman, and with foot pain, leg pain, and she wanted to get pregnant and couldn't get pregnant. And she's going, they had a lot of money. They were going to some of the best doctors, fertility doctors in Colorado. But she wasn't getting better. I ordered a testosterone test, estrogen testosterone. Her estrogen was really low. Her testosterone was really low. I called up her fertility doctor and I said, you know, her testosterone is really low. After he got done cursing me out and hanging up the phone, I said to her, well, maybe you should find somebody who will give you testosterone. In 3 months, she was pregnant. I think they named the baby after me. You know, I had nothing to do with it. But, you know, so I agree with you. We are a mixture of multiple things. Nothing works by itself. Cortisol, very important. What does that have to do with omega-3? Everything. What does the chemicals, calcium, magnesium, vitamin E, what does all that have to do with cortisol? Everything. So you need to be kind of holistic. But what's more important than being holistic is looking. What do you think? And don't trust your tests. Your tests are just tests. Period. You know, so the patient looks sick, they're sick. You know, yes. Well, once again, thank you. And we will continue this, in about 10 minutes? In 10 minutes? Or you want to go on?
Question from online? From online audience. We have a question from online audience.
Okay.
Okay. So, okay. Dr. Eileen Cho is asking, how do you treat hormonal imbalance if there's any in your clinic? Do you monitor the level afterwards?
Good question. Excellent question. Once again, you could monitor it. The problem you have in America is money. I don't know anybody else has that problem, but money is a problem. And insurance companies run by these high school graduates are very reluctant to spend money. So as one person said to me, I had ordered I ordered some test. I don't remember what it was on a young girl. And the test didn't show anything. So then I said, well, maybe we should get an MRI. So I called up the insurance company to get pre-approval. And I said, I want an MRI. The woman said, well, you just had something else. We're not spending that money. I said, ma'am, if that was your daughter, what would you say? She said, we approve the MRI. So when it's personal, it's one thing. But if it's not personal, you're not going to get another test to monitor it. You know, I don't know how to do it, but we live in a world of money. You know, and if everything was available, great. But it's not. So where is it when we ask the question? Oh, it's online. I don't know how to answer that question. It would be ideal to monitor it if you had a lab that you always use the same lab so that you know that the tests are always the same. Different labs, different tests, different results. You know, you don't really know. With all due respect to the labs, they say they all are the same. They're not. So once again, I don't have an answer for that.
If you don't mind, I can maybe echo to these questions because I'm also a board member of Bioidentical Hormone Association of Taiwan. And I think it's a good idea to monitor it because, but for testosterone, obviously a lot of men or even women have really low testosterone levels. Yeah, so you really have to test it. And but for supplementing testosterone, you also have to check TSA in case of raising the risk of prostate cancer or PTH.
How do you get around the insurance company?
Yeah, but the pricing in Taiwan is not that high, I think. Maybe lower than...
In America, it's really, really tough.
Yeah,
You know.
I think it's affordable here. So most people would be really willing to do that test.
Oh, really?
Yeah,
okay.
Yeah.
I can only speak from my experience, you know.
I see, yeah. And a lot of women would have really low levels of progesterone, and that can, you know, cause a lot of insomnia and pain and all that. And for the cortisol level, you don't want it too high because high cortisol level would inhibit collagen synthesis. It's not a good thing. But if it's too low, yeah, sometimes it means adrenal fatigue or adrenal exhaustion. So in that case, I most of the time use low dose hydroxycortisone. Or you can use licorice or glycerolic acid. Yeah.
Thank you. That's why you really want somebody who understands where you're at. Because if they don't understand where you're at, you're going nowhere.
So I think we maybe take a break.
Good.
Yeah, because this ankle food still need some time. So we take break first. Yeah, maybe just come back at 11. Yeah.
11? Fine. Okay, guys, class is out. Go to the playground. Come back. Don't get hurt.
Take a break. Yeah. 11 o'clock, we come back.
I'm really sorry about the pointer. We're trying to fix. We have two pointers, but each one's not working. I don't know why. Yeah. So then you have to keep it standing here. Yeah.
No, it's like so fine. Also, like the two people who responded in their 80s. Yeah, and it's very good for them. So I think it's just like it's good to have someone there.
Yeah. It's kind of weird because sometimes they respond, but it's not responding sometimes. It's like lagging or just.
I also think they don't know. They keep pointing at the screen. There's no
yeah, the signal is yeah.
We don't understand that.
Okay.
So
Okay.
it's okay.
Do you need a chair or something?
No,
Okay.
it's so fine. So we can just stand. It's a lot.
I'll just get a chair if you want to.
Okay, you can have a chair for that. I might go.
I'll put it here in case you want to see.
Wait. Okay, welcome back. Wait. So this was. Wait. Okay. Wait. Yes. Okay. So we are going to go to the ankle and foot now. So I think Lenny's lecture is the best lecture in the world, especially the biointegrity ankle foot. I think you cannot learn something else. Okay, somewhere else. So I think this part we will talk about ankle foot prolotherapy, and hope Lenny can demonstrate some injection technique and manual technique and the tapping technique for us.
Yes. All right. Okay.
Okay. So let's welcome Lenny again.
The thing is missing. The thing is. Okay, now we're getting. Oops, we're getting to. Did you lower that? Good. We're getting to the I call the meat of the meeting. Okay, most of you. How many of you do prolotherapy? Good, beautiful. I would hope in time that all of you will try it, and I will tell you that there are some places where you should start practicing the wrist, the shoulder, the foot, the ankle. Why? Because it's not dangerous. There's nothing there that you can really hurt. And once you get a feel for it, then you can do the back. But first, do the extremities, and then follow through with that with doing the back. And one of the things you'll hear people say, oh, that hurts. It's not your pain. Your job is to learn to help. That's where you're at. Okay, prolotherapy, what is it? How does it work? Okay. By the end of the session, I want to give you a brief history about prolotherapy. And number one, I want to describe how prolotherapy aids in ligament repair. So you need to know where it comes from. Where are we going with it? What are the problems? What are the steps? Okay, prolotherapy is a very elegant and very simple, inexpensive way of treating joint musculoskeletal dysfunctions. It stimulates, proliferates, why it's called prolotherapy. It proliferates the ligaments and the tendons by bringing in what comes in? What makes it heal?
Fibroblast.
Fibroblast. So everybody understand that. Fibroblast is the essence of where we're at. They should be in bed with you. Okay. So what it does, it proliferates the ligament, and by proliferating it and putting more ligaments down, you get a stronger bond. That's what you want. You want a stronger bond. Now, the first time that we know about historically is that we're in Greece in about the 4th century BCE, Hippocrates treated a spear thrower who had a bad shoulder. And if you're a spear thrower and you have a bad shoulder, you can't throw the spear. So he took a hot iron and poked it into the ligament in the shoulder joint, and it got better. The pharaohs in Egypt used to treat their horses like that. When they would have hoof problems, they would do the same thing. Though in a form, they were doing prolotherapy. George Hackett in the United States started doing this. He was an orthopedic surgeon in Ohio, and he was at the medical school, and he had his students, like they're crazy, would come in, and he would inject different ligaments, and he would, with a hyper saline solution, hurt like the dickens, and he'd say, okay, where does the pain go? Now, I don't know when I was a student that I'd been so willing to have somebody inject something that I know was going to hurt. So all of these Hackett points that we hold like a religious emblem came from some crazy students who had no money and were willing to be the guinea pig. That's where you get the Hackett points from. Then our own Bjorn Eck did one of the original research programs that was written up in the journal back in 1997. It was a million years ago, Bjorn. We were young and good looking. I don't know what the hell happened. But Bjorn and Robert Klein, who was his partner in crime, and both of them are brilliant people, in 1997 did a research project that he proved statistically that 80% of the people that they treated with prolotherapy got better. He was along with Angley and a whole group of other crazy people. I mean, some of them were really crazy. And so that was that. That's our Bjorn Eck. Alan Banks, who lived in Colorado, and he was a chemist. He wrote the whole cascade chemistry of what happened when you would inject the glucose into the ligament. He broke it down chemically. Great guy. And the way he got involved in it is that he had a bad ankle and a bad foot. He was an athlete, and he was treated by me and Tom Raven. And that's where this came from. Dorman and Raven, both of them in America, both of them, one in Colorado, the other one in California, crazier than the Dickens, wrote a little red book that is well worth having. And where they talked about injection therapy. You have Hackett's book, which is a classic, which you should get if you like to read, and they talk about it. So there are enough outside paper right now. There are people working at the University of Wisconsin who are also involved in the research program. So this is not some off-of-the-wall kind of stuff, something we make up when we're sleeping. This is really well-researched and well-documented. Because many times when you'll tell your colleague, well, what are you injecting? Glucose. You're crazy. You're going beyond the realms of medicine. Well, there's well-researched, documented stuff out there that you should have, at least in your computer, so you can say, let me send you the paper. They're not going to read it, but, whatever. You know that, right? Nobody reads anything. Okay. Prolotherapy is nothing more than another tool in your toolbox to get people better. That's all it is. It is not a miracle. When I first got involved in it, I thought it was, but it isn't. It's just another tool that we get to play with in our toolbox to figure out how to get people better. In the foot, it is really, how many of us see plantar fasciitis? Everybody comes in, what is wrong with it? He's got plantar fasciitis. That's nice. What the heck is that? Nothing. So plantar fasciitis, ankle instability. And you will think that ankle instability is only in young people. It's not. What about us old folk who our ligaments get loose, and as we walk, you can see how I walk somewhat unsteady. What's going on in my ankle joints? What's going on in my knees? What's going on in my back? So do not think that ligaments are only in young people. Us old folk also have ligaments, and they also, without trauma, get age. Consequently, when you see older people with back issues, shoulder issues, knee issues, foot issues, it's ligaments. It doesn't matter when they're age. Unstable wrist and ankle and arm joints, knees, all of that generally is due to ligament. Arthritis. Why do we have arthritis? We have arthritis because when we were created, our joints were in good alignment. As we get older and our ligaments relax, we go off a joint and we put too much pressure on one side or the other. John Trister in America, I don't know if any of you know John, John treats all arthritis in the foot, the hand, by prolotherapy. What does he do? He tightens the ligaments surrounding the joint to give the joint better movement. I used a lot of whole blood intra-articularly to help as a cushion and also to help regenerate some of the hyaline cartilage, which they say cannot be regenerated. It can. Okay. Ligament strength increased. I think Bjorn did this. Did you, Bjorn? Or somebody did it. When they did prolotherapy and they tested it, it was in rabbits. They found when they sacrificed the rabbit, they found that the ligament by the microscope had increased by over 50% in rabbits. And what they would do, they would inject the rabbit, and then they put them on a treadmill, and then they would sacrifice them, and then they would look at the tissue, and that's what they found. Ligament tensile strength was better by 100% in a year's time. Amazing. And that was Tom Dorman, who did that research out of UCLA. Okay, now the hypersomatic solution of dextrose, I use 25%. Bjorn, I think, uses 10% or 15%. I'm terrible in math. Horrible. I'm dyslexic. Consequently, if you would say make an 18% or a 12%, I can't do that. It's beyond my ability. But I can take 50% of dextrose, divide it in half, and get a 25% thing. So I use 25%. Why did I use 25%? Because I found it worked for me in my ability in order to get things together. Did I find any problem with it? None. Actually, it worked just as well at 25% as at 10%. And what it does, what we think it does, is when you put hypertonic solution into a thing, you have osmosis. Well, osmosis draws the water out, which destroys the cell, which makes which causes the cell to die, which brings in fibroblasts and fibroclasts, and which destroys the dead tissue, which now promotes the fibroblasts to come in to promote good tissue. So you're setting up this cascade of healing that we need. Okay. Simple chemistry. Simple chemistry. And this is what I use in my practice. I understand now in America it's hard to get dextrose. Is it, Bjorn? It's hard. But so I would buy boxes of this 50% dextrose, and I take out half of it, put procaine in the other half, so now I have a 25% solution, and it worked for me really well. I also would put in vitamin B12. Why did I put vitamin B12 in? What color is vitamin B12? Red. When patients see red, they know you're doing something, And also, most of the people I saw were older people, and I lived in a place called West Virginia. The nutrition there was potatoes, and alcohol. And smoke. Don't forget smoking. So what happened to their blood sugar? What happened to their protein levels? Proteins are expensive. And you remember the B12 comes by how? When I eat meat, it grinds it up and I get B12. But if I don't eat meat, what happens to my B12? So when I would put B12 in and I would use that as part of my prolotherapy, I accomplished two things. One, it was red. That means I did something. Number two, they felt better. Why? Because I boosted their B12 level. Of course they felt better. Okay. Now you have to go back to what works. And we can't fight Mother Nature. Mother Nature tells us that the inflammatory process is between 1 and 10 days. That means if I inject between 1 to 10 days, I'm doing nothing. And then granulation is 10 to 30 days. So I would schedule patients 3.5 weeks out, and they come in, if they came in, because nobody likes to get injected, and I would re-inject it, and that would help the inflammatory process go on. And healing took between 1 month and a year. But they really felt a lot better. Plus, at that time, I used a lot of taping, a lot of exercise. I did a lot of other stuff. Because, like I told you, prolotherapy is just a tool. A tool by itself. A hammer without a nail is nothing. A hammer and a nail, that's something. So you got to now look at the global picture. And this is a picture which we all learned in school, the classic concept of the inflammatory process. Nothing new here. It hasn't changed since we've been here. Okay, what do I do after I do the treatment? Well, the first thing, they're going to hurt most of the time. Although with the lidocaine, I found that and being gentle with tissue, I didn't have much pain at all. Actually, I would tell the patient, this is really going to hurt. And then they come back and they said, you lied to me. It didn't hurt at all. And I realized that by respecting the tissue, and if you were a surgeon, the most important thing was to respect the tissue, then you did not get as much inflammatory process. Mother Nature worked well. They got a little bruise, but it was nothing that they couldn't handle. Number two, I never, ever, I think in 20 years, I may have used 5 cc's of cortisone in my whole practice. It was at a little vial tucked away somewhere. Because if it's available, you'll use it. If it's not available, you're not going to use it. So if you put things away that you can't get to it, you won't cheat. Otherwise, you'll cheat and say, oh, came in with pain, I'll give you a shot of cortisone, you'll feel better. If I don't have it, I don't use it, I'm better. The patient's better off. And then in America, for a while there, you couldn't get cortisone. What did the asthmatic do? I have no idea. But there was a big time there where there was no cortisone available to anybody. So I don't know what they did. So that was one. And what does cortisone do? Cortisone reduces inflammation. Reduce inflammation, reduce fibroblast. Reduce fibroblast, reduce healing. Okay? More scar tissue. That's not what you want. So put the cortisone in the upper shelf, and if you're only 5'5", put it up at 6 feet. And keep a nurse who's shorter than 6 feet to get to it. You know, because otherwise you're going to use it and cheat. Don't cheat. Okay? And who said this to us was Jeff Patterson of blessed memory, who some of you knew. And Jeff was amazing. And what Jeff used to say, most amazing guy, you see these fingers? They are my MRI. Jeff never, he was at the University of Wisconsin, never ordered an MRI. Oh, my daughter's back again. Actually, my granddaughter. He never used an MRI. He would say, let my hands do the walking. And Bjorn and I were talking about it. Patients would come in, and I would scan their x-ray. And I could say, oh, this is where you have your pain. Bjorn does it. He scans the body, and he feels the energy. You all have that God-given gift to do that. But you have to train yourself to be extra body. You have to be outside of your body. You have to be Star Wars. Do the scan. And the more you do it, the more you understand it. I would really suggest that you read the book, The Musculoskeletal Train. When I first read it, I was sure the guy stole it from me. But you would come in, patients would come in, and I said, oh, that hurt. So your shoulder also is sore, or your neck is sore. How did you know that? Well, how I knew it because I used to draw maps, and patients would come in with pain maps. And I would see where they would put the pain. And I would then be able to see patterns. And the pattern that I always found was diagonalization. If I had pain in my right knee, I'd always have pain in my left hip. If I had pain in my left hip, I'd have pain in my right shoulder. And it went on. So now when you came in, you said, oh, I got pain in my right ankle. I knew that you were going to have pain in your right hip and your left shoulder. So I could say to you with very little fear of being wrong, oh, and your shoulder hurts you too, right? How did you know that? I looked at the pain map. Okay. Now, what do you not want to do in prolotherapy? Number one, if the person doesn't know what you're doing, or they're afraid of needles, don't do it. Don't do it, because no matter what you do, it's going to fail. If the patient isn't convinced that you're God, don't do it. It's not going to work. And how many patients are absolutely frightened to death of needles? And they see that needle and they panic. What happens when you panic? What goes up? Your cortisol goes up. Your white cells go up. Everything gets higher. So how is prolotherapy going to help? It's not. Why? Because everything is working against it. It's fight, flight, or fight. You're not going to do it. So if the patient is frightened, don't do it. What I did in my practice was, I'll show you. I would first anesthetize the part. I had television in every room with earphones. I'd leave a patient there in the room, watch television, and I'd leave for 10, 20 minutes. Why did I leave? For two reasons. One, I had other patients to see, and two, they kind of relaxed. You know, so that's something to think about. Also, you may want to give them an anti-anxiety pill for something to quiet them down. If you use hypnosis, that's fine. Nitrous oxide, it's fine. Whatever you do, quiet them down. There won't be that much resistance. If there's a local infection, and I would tell you if there's an infection almost anywhere in the body, not a great idea, because the body has to make a decision. Where am I going to bring the healing? And the body will always take infection over everything else. So if they have an infection, don't do prolotherapy. If they have neurological diseases, well, I can tell you from my own personal experiences that the muscles cannot be in tone. So no matter what you do is not going to work long term. But then again, you have to think, what do I really want to do? What am I looking to accomplish? Do I want to make them a runner? Or do I just want them to be able to get along? So you need to make up in your own mind, what do you wish to accomplish? And then based on that will be how aggressive you're going to be. My wife died of a neurological disease. It didn't matter if I said, you've got to exercise. She couldn't exercise. So what difference, if I did prolotherapy on her, I wasn't doing it to strengthen anything because it wasn't going to work. So you need to know, what are you doing it and why are you doing it? If they have a systemic illness, a virus, like Bjorn talked about earlier, they come in with AIDS or they come in with herpes or whatever else, you're not going to get such a great results. Know that and tell that to the patient. You have an infection or you have some systemic issues. I can only do what I can do. I can't do more than what I can do. And finally, if you have a depressed hormonal system, it's not going to work. When do you have depressed hormonal system? Mostly in women with abusive husbands. They come in, and there was one woman, her name was Andrea Dawson. And you know, never forget your failures. I can guarantee you. I was a surgeon. I did 7 surgeries on her. I was able to give her reflex sympathetic dystrophy, ultimately. But what I didn't know, that she had 2 German shepherds. Her husband had 2 German shepherds in the yard that she was deathly afraid of, plus a very abusive husband. So psychologically, she was having all that issues that I had no understanding about. And of course, everything I did was going to fail. And I was being very invasive. So definitely everything I did failed. So, and ultimately, her hormonal system were in a defense. So she was in flight, not fight. Consequently, that was the issue. Now, one of the things you would like to do when the patient comes in, young or old, is you'd like to check what their protein levels are. What do you eat? Oh, I eat a big vegetable diet. Great. What do you get for protein? Nothing. Great. How are you going to heal? I don't know. So you want to do a bone density. If they're osteoporotic, what are you really doing? What are you going to get done? How much minerals? Do you take any minerals? No. Like what? Calcium, magnesium? No. Do you take omega-3s? No. You do this? No. So you have to understand that you're not going to get great results. So it may be in your clinic, you would like to sell, give, do whatever you want, they're cheap, a packet of medicine. I'm going to start prolotherapy on you in a week or 2. But in the meanwhile, I want you to take these packets of pills every single day. They're free. And I want you to bring me in the the bag that I give it to. So I gave you 10 bags. I'm going to have 10 bags back. That way I know that you should be taking your pill, because otherwise they're not taking it. So you want to give them a guilt trip that they're going to do it. And you may want to do that before you start your treatment. But if their minerals and vitamins are low, you're not going to get what you want to get no matter who's paying for it. Okay, stop your anti-prostaglandin therapy. That means aspirin, non-steroidals, red rice maybe. Red rice has statins in it. So you want to stop that at least for 2 weeks prior to treatment. That's important. Not really certain how important it is, but it is important. But if a person has had a heart attack, you really don't want to stop their aspirin. Why? The jury is out about how effective aspirin really is. I speak to my cardiologist. I've had 2 heart attacks. I've spoken to my cardiologist, and he wasn't really hot on the idea of that. He said, take it because you never know what's going on. And if you don't take it and you die, it's my problem. So if you're taking aspirin, you're taking 0.5 milligrams. It's nothing. Keep taking aspirin. Acetaminophen, Tylenol is fine. That does not seem to interfere. And then before they leave your office and before you inject, you tell them, this is going to hurt. Get used to it, huh? The battery's out. Okay. There's a technical change. This is like your computer. When your computer says it hangs up and you're waiting for it to do something, that's this. Okay, Jonathan, let's go forward. Okay, know where you're going to inject and why. Just putting glucose or whatever you put in there isn't going to work if you don't know where you're at. There's a saying. And I think I told you that, any port for the sailor who doesn't know where he's going is a good port. It doesn't work like that in prolotherapy or in medicine. If you don't know what you're doing, don't do it. So that's important. And then for me, I only wanted my needle to be on bone. Now, I haven't decided in my head exactly why I was doing that. It could have been this. It could have been that the glucose was really doing something, or it could be that I was stimulating the periosteum. Did it make a difference? Not really. Did it get better? Yeah. So, okay. But if on a scientific part, I wasn't really sure what I was doing. And also, it's important that when you're injecting and you know where you're at, and I would tell you if you're doing a shoulder, a foot, an ankle, and I'll bring it tomorrow, it's good to have a model with you because you're doing it blind. And if you have a physical model in front of you, then you can say, I should be here. And the models today are so accurate that you can know exactly where you are just by looking at the model. Very important. And only inject a little bit, because you don't need more than a little bit. I like to mobilize. I like movement. Because if I injected the joint, I'm going to put the joint back in place. That's how I got this arthritic thumb. Kept putting the cuboid back in place. And after you do it for a while, you'll get arthritis, which hurts. I wish I had to use something else. And then for me in the foot, because the foot is a weight-bearing organ, I want to use flexible tape, because I want to keep, while my prolotherapy is working, I want to keep things in alignment. Frederick, can we get tape for tomorrow? Tape? You have tape? Good. So I'll teach you how to tape a foot and an ankle. Really, really important. And I would think when I did a back or a shoulder that I would also want to restrict the motions. And remember what I taught you about Hilton's law? The skin above affects the muscle below. So if I put tape on the skin and under tension, what's going to happen to the muscle? The muscle is also going to be inhibited. So tape is important because tape, Hilton's law, teaches me that the skin above, the nerve that innervates the skin above, is going to innervate the muscle and the joint below. So if I can restrict the skin, I'm going to restrict the motion of the joint so the joint has a chance to heal. And I'll teach you that tomorrow. Absolutely essential. You can do more with just plain tape. And remember, the tape doesn't have to be strong. I use paper tape. Why? Because all I want to do is to tell the skin what I want the joint to do. I'm not interested in restricting motion. I'm interested in to get the body to use the body's repair mechanism to treat it. Okay? Exercise. Use it or lose it. And this is a new revelation to me because I, who hate exercise, my grandson goes to exercise, and I said, I'll read and stay in bed. So he goes exercise. I don't. I go to the gym 2-3 times a week in Israel, and every time I go in, I hate this place. I really don't like it. I don't like doing all the weight that he has me do. I don't like the running. I don't like any of that. I'd really rather read. But, okay, I do it, and I am feeling a whole bunch better because I'm doing it, but I hate it. Okay. Next. Okay. So, once again, an advancement in who I am, a referral to a physical therapist. And the problem with a physical therapist is most of them don't understand what you're trying to accomplish. They got their parameters. You got your parameters. So you really, have to find some physical therapist who understands you. Because they don't understand you, you're at cross purposes. They want to do this. You don't want them to do that. Like my physical therapist wants me to lift weights, stretches, and all that. And I keep telling him, you're tearing the joint. Doesn't care. He was taught that I need to stretch. Good for you. You stretch. Leave me alone. Okay. Proprioceptive exercises are really important. And the best thing is the ball. Just get a big beach ball. especially in the back, sit on the ball when you're in front of the computer, and the ball will move, and you're going to get your muscles to move, or the rebounder, or whatever you want. You want to coordinate the eyes with the rest of the body. Remember what I said to you about Lung Chao? Every journey of 1,000 miles begins where? In the eyes. So let's say you're a tennis person who wants to be a tennis champion or a basketball team. What do you want to do? You want to get a rebounder and let him jump on the rebounder and hit the ball or shoot the basket. Why? Because you're training the motion and the eye to work together. Very, very important. And I used to do it. And one guy came in, I had his wife on that doing the rebounder. And he said, oh, that's simple. I said, great, you do it. Couldn't do it. So, okay, it's not as easy as it looked. The Swedish ball, which I do like to sit down in front of the computer with, I don't do it. But I would recommend that you recommend everybody else to do it. It's good for the other person. Pilates is excellent. Don't do that either. But it's really good to do for everybody else. You should enjoy yourself and have a long life. Next. Okay, now, do we know what? Do we know a brief history of prolotherapy? Bjorn Eck. All you have to remember is Bjorn Eck and Robert Klein. That's your answer. You do know it. And you know that it was done way back in the time of the pharaohs. So when you read the good book, you understand that they knew prolotherapy better than we do. Can you describe how prolotherapy aids in ligament healing? Of course. How is it? What word are we looking for? Jonathan? Fibroblast. That's it. Good. Jonathan knows it. I expect you guys to know it too. And what do you do after physical prolotherapy? Exercise, vitamin, rebounding, whatever you do something. Okay. Thank you all. That's it. Okay, we're going to come back. We have an ankle and a foot. The two things. And they're the stepchild. What?
We don't have so much time. So
we can do it now. Yeah, I'm like the ever ready buddy. Okay, we're going to go to the ankle joint. Close that one out, Jonathan. Can you get to the computer? Here comes our man, Achilles. Thank God for grandchildren. Otherwise, my clock would still be saying 12. 12, 12, 12. And I can't change it. No, okay, go to the top. Go to the first. No, go to the top. Can you get? Okay, we're going to talk now about the prolotherapy for the foot and ankle. You would be surprised, and I know that most of you think about the low back, but you would be surprised how much you can treat by treating the foot and ankle that will solve your back problems. And let's do that. That's called an idiot. Or a teenager, I don't know, one or the other, you know. Here's one of the great tennis players, and look at his ankle joint. He's having an inversion sprain, but because he is so strong, he is able to do that. And when you injure your ankle, you not only injure your ankle, you injure the knee, the hip, the low back, the shoulder. All of that in the idea of tensegrity are all part of the issue. So if you don't address the instability in the ankle, it really doesn't matter what you do to the shoulder, because when a person walks, what do? They swing their arm. So if the ankle is sore, they're not going to swing the arm. Then what's going to happen to their gait? Their gait's going to get messed up. So you have to look, once again, I have a shoulder problem. Let me see you walk. Oh, you have an attenuated gait? Maybe that's the reason why I'm having a shoulder problem. So you can do all the prolotherapy you want on the shoulder, but if I don't fix the arm swing, it's not going to work. I had a young man that they flew in for me to see from Mexico, which is a pretty big distance away, and this young boy walked like this. I asked the mother, and they brought him to me to see. I asked the mother, I said, was this child had a forceps delivery? She said, yes. I said, well, what happened in the forceps delivery is they injured the shoulder. And therefore, and you could see when he walked, he didn't move one shoulder. So what did I do? I gave him a roll of pennies to hold. Wait. And when he walked, he swung the pennies. All of a sudden, his gait got better. So you can see there's an interconnection between the two. Next person. Guy came in, chronic knee pain. Oh, and he had prolotherapy, he had physical therapy, he had medicine, still thing. I said, okay, walk. He walked. And I had, Robert Klein was there. Germany was there. Tom Raven was there. They were really, I considered some of the very best people. Dietrich was there. And I said, okay, did you see what he walked? No. I said, walk again. He walked into the wall. I said, you need new glasses. He said, oh, that's funny. My optometrist told me I needed new glasses because his gait was off, so he was trying to compensate, unbeknownst to him, with his knee. But when he got new glasses, the problem in his knee got better. So you need to look. And the more you look, the more you see. You see what you know what you see. If you don't know, you don't see it. I never saw that. How many times your kids come in and say, I looked, I couldn't find it. Yeah, of course you looked. You know. Okay. So low ankle sprain ligaments is 10% of the ankle sprain, although the books will tell you that it was 90%, but they're wrong. And you have an anterior talofibular sprain, the sinus tarsi, posterior talofibular, calcaneus. That's what they call a low ankle sprain. Now, a high ankle sprain, which in my opinion is 100%, but I gave it 90% because I didn't want somebody to say, well, you're exaggerating it. And the high ankle sprain, and I'll show you it, causes all of these different problems to happen. And it's all mechanical. It's all mechanical. It's just like taking a wrench and moving a bolt. So you see what happens to the talus? The talus moves in a low ankle sprain and it pushes the fibula out. What's holding the fibula together is the interosseous ligament. What am I doing to the interosseous ligament? I'm tearing it. That's a high ankle sprain. When the fibula is loose, where does the fibula end? In the knee. The fibula is part of the posterior cruciate ligament. So if I injure the ankle, what am I going to do to the knee? I'm going to be injuring the knee. It may not show up now, but it will. So you need to be very thin. So if a person comes in with a knee problem, what am I going to inspect? I'm going to inspect the fibula at the superior and at the inferior part. If I look at the ankle joint, what else am I going to look at? I'm going to look at the foot. I'm going to see how is the foot functioning. It doesn't help me to treat the knee if the pathology isn't taken care of. It's a waste of time. Yes, the person will get better because that's how we're built. We do get better, but it won't last. And what we're looking for is permanency. We're trying to put ourselves out of business. Okay, so you can see the interosseous membrane and the syndesmosis, which is really easy to get to, is high up, and it is torn apart vigorously by the movement of the talus against the fibula. That's why I'm saying there's no such thing as a low ankle sprain. All ankle sprain has got to include the movement of the talus. If I'm moving the talus, I'm using a lever to move the fibula. Okay? Here's an x-ray of a low ankle sprain that never got better. That I'm in a cast, all that. I took an x-ray. This is my x-ray. And you can see where the ligaments are screwed up. They're wide open. And here are some of the things that we are used to. And that's basketball, football. They call football soccer where I'm from, but I still think of football as football. And think of this. You're not going to see these people. They have professional trainers. Who are you going to see? You're going to see the little old lady or the little old man coming in complaining of knee pain. Ah, maybe that's where the bread and butter is. Okay? This is what it looks after an acute injury. I have a hematoma. But I would tell you, look at this not as a child. Look at this as an adult or a senior citizen. One of the things you do when the patient is sitting down, see if you can, what is your range of motion in that ankle joint? You'll know, as Bjorn told you, that it is lax. You can see the increased motion. You know right then, that's not normal. Something else is happening. I need to do something. How many times when you're walking, and you go to the airport, I love watching people in the airport because they're totally unaware what the hell's going, and they're in a hurry, and they'll twist their ankle, and they'll keep walking. You know, they got to get to the airplane. The heck with the ankle. They got to get to the airplane. Or you watch people walking in the street. They'll twist their ankle. They keep walking. They step off of a curb. They keep walking. But even with that, when they come to see you with knee pain, check the ankle. And this is what it looks like. You see what happens to the talus? How it's acting as a lever to throw out the fibula, which is throwing out the knee, and it's throwing out the hip, and it's throwing out the shoulder. It's all the same. That's what it looks like in the anatomy books. Does it really look like that? Nah, not really. If any of you have ever done surgery and you're trying to figure out what it looks like, it does not look like this. And when you look at it, you really want to look at the calcaneofibular ligament and the anterior talofibular, which is the most common injury in golfers. Any of you treat golfers? You know what golf is? Yeah, I'm sure you do. But when you get up to address the ball and you come through, what are you doing to your ankle? You're putting it into eversion, and you're tearing the ligaments in the ankle joint. So the easiest treatment there is just to treat the anterior tibiofibular talofibular ligament and look at the calcaneofibular ligament. They're not torn. They're just injured. They don't have enough fibers in there to hold things stable. And you can see. That's the x-ray. Okay, now one of the parts that you all will miss, everybody misses, is the posterior portion of the ankle joint. The easiest joint, the easiest ligament to get to, the least dangerous of all the ligaments is the posterior calcaneal ligament and capsule. And the fibula. You can get all of it with one injection, and you have nothing, there's nothing important there except for one thing. And that's not even important, is the sural nerve. And if you go near the sural nerve, they will really jump. And you say, oh, good, I meant to do that, you know, because it's like hitting a raw nerve in your tooth. Whoa, it sends shock. But it's okay. It's a sensory nerve. It's not doing anything. Okay? And the lateral portion of the ankle joint is one of the most important parts. Coming in from the lateral, there's all your ligaments. Okay? Bisect the Achilles, your fibula. And there's the artery. I didn't draw out here the sinus, at the talo ridge, which where the deltoid goes in, because I didn't think it was really important then. I kind of changed my mind. You know, thinking men think, thinking men change their mind. Now, I'm telling you, after I did my prolo, I'm putting a very simple strap to hold the thing, Hilton's Law, very simple to do. And then I am going to follow the ligaments around, and you can see the marks where I injected it, and you can see I'm using paper tape, which is easily torn, easy to do, inexpensive. And in America, I hate to tell you, it's a code that you can charge for. You know, taping is a code, and that's it. That's the whole taping of the ankle joint. And it works tremendously. Another place when you do knees, do the same thing on the dorsal, on the superior part of the knee. We did that with a son of a friend of mine who was a football player, American football, and he ran faster. And now when you see a lot of runners, they all have straps around the upper part of their knee. What are they doing? They're stopping the movement of the fibula, which allows the peroneus longus to function better. And if the peroneus function better, the anterior tibial is going to function better. And the anterior tibial is a slave to the posterior tibial, which is an inverter and and raises the heel of the foot. So those are whatever. And the posterior tibial and the fibula is where the posterior cruciate comes from. So if you don't look at that, you've missed the whole knee. So you'll go in, I'm injecting the posterior cruciate ligament. Congratulations. What about where it comes from? Oh, it comes from the ankle joint. Oh, really? I don't need to do that. Fine. Okay. And you can see I just injected it. I'm mobilizing it. and it's all in good alignment. I'm going to tape it afterwards, okay, Jonathan? And she can move it. This is just another tape. And I'm going to inject the interosseous ligament and the fibula. She's already numb. And you see the red, don't you? That's called B12. And I'm right on the bone, as you can see. And I like the 25 red gauge needle because it will do whatever you think it should do. It goes where your mind is. And now, this is the dorsal part of the fibula. And let me inject. There happens to be a nerve there. You want to give somebody drop foot? And you can see this person a little overweight, a little bit older than 20, you know. And I'm putting the talus back in his socket. There, I can feel it. And now I'm going to do a knee motion. I'm putting the fibula back into place. Boom. And I'm activating the anterior and the perineal muscle just by doing muscle tension, this muscle stretch. And they're fine. Okay, John. And I'm taking it. I like this kind of tape because it's very flexible. It allows for movement and restriction at the same time. And you don't put it on tight. Just put it on. Just follow the ligaments. I'm done. Had a lot of tape. Okay, you can move forward. Okay, what's the purpose of manipulation after prolotherapy? Anybody? Speak up. Putting the joint back into its natural position. Okay, why is taping critical? Because the body has to learn what you want it to do. Like, any of you ever ridden a horse? Any of you gone horseback riding? Nobody? Why do you have a bridle? Because you want the horse to do what you want the horse to do. So you put a bridle and you hurt it so that it does what you want it to do. And what other injuries may be sustained in a sprained ankle? Knee, back, shoulder, neck, all of that. Thank you, guys. These are the hills of West Virginia. Okay, we're ready to go and do the foot round. Okay. See, Achilles, you are worth something. By the way, thank you, Jonathan. Yeah. Go to the top. No, go to the very top. All the way up. Good. Okay. Okay, guys. It's prolo of the foot. The most effective treatment I have ever found for foot problems, ankle problems, knee problem. Yes, I was a surgeon, and my answer to patients were when they came in the office, if you don't want to get cut, go find another doctor. You know, and then I'm a pretty critical guy. I went over about 10, 15 years out, and I went and looked at the patient, at their record. How's your foot? Oh, my foot's great. How's your knee? Oh, it's hurting me. How's your back? It's hurting me. I kept seeing this over and over and over again. So I kept thinking, maybe there's something I'm doing wrong. And then a good friend of most of ours, John Trister, calls me up one day and tells me about a lady who she had a bunion surgery. She now has scoliosis. She now has neck issues, hip issues, all of that because why? She wanted to look beautiful and wear beautiful shoes. They operated her bunion. They changed her entire tensegrity issues. And now she has so many other problems. So the foot has three functions. One, it supports the body. And you need to learn, as physiatrists, you need to learn the 7 stages of gait. Most important. If you don't know it, go back to the books and learn it. It's more important than you'll ever know because the whole body works around that. Second thing is a shock absorber. I'm walking. I weigh I want to say 75 kilos. I would like to weigh 65, but I now weigh 75. And when I hit, where's all that shock going? To my low back. Why did God make us have so many joints? I would make you all with one joint. Save money. But what happened? We have all these joints. Why? To dissipate the shock wave as it travels up the body. And you need the shock wave to get the muscles to work. So it's all kind of figured out. And third, it's a moment arm for accelerator to go forward. And it's also a decelerator to stop body motion. Okay? And there's a lot of bones in the foot. Every bone is a shock absorber. Every bone has a reason for being there. When you compare our foot to the gorilla foot, where the difference seems to be is in the bunion joint. Because we are not prehensile. Most people can't use their toes to hold pens. Although I had a patient that could. She was born with no arms. Most amazingly, Victoria. But each bone does something different for a different reason. Ubiquitous plantar fasciitis. It's not plantar fasciitis. It's plantar fasciosis. If you talk to the radiologist, everything by them is plantar fasciitis. And when I said to my friend Steve, well, it's a plantar fasciosis. There's a tear in it. He said, no, we call it fasciitis. That's nice, but that's not what it is. But okay. So what is the plantar fascia? And I'm going to dwell on that most because that's one of the things I like. I had just moved to West Virginia from Denver, big city to a little city. And I had no patients and I was bored. I get bored very easy. So I went to the medical school, which was about maybe 50, 60 miles away. And I happened to know a few people in there. And they said, sure, you want to use the anatomy lab? More than happy. Because I had a theory and I wanted to see it. The only way I could see it was on a cadaver. So if it's possible, can we go back to the first slide? No, not the first, there, stop there. I want you to look at the heel bone. Now, how many of you have seen x-rays of children before the age of 14 in the foot? You have 2 growth centers there. And you've all heard of Sever's disease, have you not? Everybody's heard of Sever's disease. What is Sever's disease? It's the osteochondritis of the posterior aspect of the calcaneus. My feelings were that they're really two bones, that the posterior aspect of the calcaneus is a separate bone, more like a sesamoid than like a bone, like a solid bone. And the only way I could prove that to myself was to have a cadaver. So they gave me my own cadaver with a little old lady from God knows when, you know. So I thought I've been doing surgery, so I thought I was a great anatomist. Wrong. Anyway, I opened up the heel. I took my mallet and I laid it on the Pacille's line, which is the imaginary line from where the posterior part of the calcaneus goes to the body of the calcaneus about the age of 14. And I went, tap. And you know what happened? It separated. This is a 70-year-old lady. For God's sakes, it should be solid. And if you look at the X-ray, it is solid. But no, there's a fault line there. And I came apart. And what's attached, do you think, to the posterior aspect of the calcaneus? The long tendon of the gastrocnemius muscle. So what is the plantar fascia? It is the long tendon of the gastroc. And what did I tell you, if you remember, about the about when they did transplant in stomach surgery? You lost the cilia because it changed, because it adapted to its new purpose. So what happens to the gastric muscle? Here it's muscle. Now it's tendon. Now it's got a different purpose, so it becomes the long tendon, stronger than the tendon that you see in the heel, but because why? Now it's supporting the weight. So it's the same tendon. And I dissected it away, and lo and behold, it became the long tendon of the gastric muscle. Knowing that one thing is going to change how you're going to treat the plantar fascia. And most people will come in, and most doctors say, I'm sending you a plantar fasciitis. I'm sending you a plantar fasciitis. And I'm only allowing you 3 visits to get them better. 3 visits, I'm supposed to heal the world. And you can do it. So let's go forward, Jonathan. Let's go back one, please. Which is the extension of the biceps femoris that attaches to the ischial tuberosity. So let's follow the gastrocnemius up through the posterior knee to its ultimate insertion. Where's the ultimate insertion? Into the ischial tuberosity. Just remember, the muscle is one long continuum. And you have to look at it as one long continuum. And so when a person has ischial pain, or they tear their hamstring, which seems to be a big issue, what do you want to do? You want to look at that whole structure. I have ischial tuberosity bursitis. What do I really have? Where am I really going with all of this? I would suspect, I would hope, that you will now start following things to their ultimate insertions. Okay? So let's look how it works. Go, Jonathan. You see how it just follows through. That is what dissection shows you. So you can argue that it's not, but I can tell you my experience is that it is. You just have to either take my word or get your own cadaver, one way or the other. And now we can see, you see the 2 heads, the lateral and the medial head. It comes into the long thing. And what other muscle is there? There are 2 other muscles there. What is it? Soleus, and there's one more. Plantaris, which I was informed when I was a student and I was doing my dissection, as we all did. I saw this long, thin muscle. I went to Dr. Brighton, our anatomist. I said, Dr. Brighton, I can't find this nerve in Gray's Anatomy. We didn't have Cunningham and all that. He said, yes. So I went home, I studied it, came back, I said, I can't find it. He said, it's called the freshman's nerve. Really? He said, yeah, it's the plantaris, stupid. So, and it's easily torn, and it's of really no value, only if you're an expert tennis player. If you don't play tennis, forget about it. But the soleus attaches to the heel. The plantar fascia attaches to the metatarsal. They're 2 different muscles doing 2 different things at 2 different times. And as I was talking to Bjorn, we have muscles. We have monophasic and biphasic muscles. Look at your muscle. How many times in the gait cycle do they fire? It will tell you what the muscle does. Mother Nature doesn't make mistakes. We call them freaks when she does. But if she doesn't make mistakes, so now look at is it a biphasic muscle or a monophasic muscle? It will tell you a lot. And this is what it looks like on the bottom of the foot. It does not look like that at the bottom of the foot. That's the drawing of what it should look like at the bottom of the foot. Okay? And that's another drawing. Now, what is the use of the plantar fascia? If it's the long tendon of the bicep, of the gastroc, which is the long tendon extension of the bicep, which becomes the ischial tuberosity, what does it do? When I'm on single stage fans, it stabilizes my ischium, which stabilizes the movement of my pelvic. Is that important? I don't know. That's your decision. But so when you think of the foot, remember that the foot is the mechanics that are going to control the movement of the ilium and ischium. Is that important? I think so. Okay? And so you have the spring ligament and the dorsal acute. There's a lot of ligament. And when you do dissection, unless you're an anatomist, they all look alike. It's just one big mesh, which is great for us prolotherapists. You know? Okay? And the deltoid, which is totally different from the other one. The problem with the deltoid, and that's why I asked Frederick to give me some diabetic syringes, that right next to the deltoid ligament is the posterior tibial artery and nerve. And if you slip, you're right in the nerve of the artery. Not a good place to be. Okay, the spring ligament, I call it the bra. It holds the talus up when I'm walking, and I go from heel strike to mid stance, and I want to pronate. Now you'll hear people say, what's wrong with you? I pronate. Everybody pronates. You have to pronate. And pronate only works one place, the wrist. The foot, they didn't know what the heck to do with it. You know, yeah, that's what you think now. But the truth is, in the beginning, they didn't know what to call it. So it did this, so they call it pronation. Is it pronation? Oh, okay. That's what we call it. So the spring ligament is the bra that holds the head of the talus. It's very, very important. And if you think about your gait, I have heel strike, mid stance, I'm carrying, and I'm single limb, So I'm carrying all of my 75 kilos on one limb, and I'm moving in with my knee. And what does this spring ligament do? It holds my foot in a position that will now allow me to toe off. If my foot collapses, then I can't engage my perineal muscle to help my flexor extensor digitorum longus to toe off. It's all, so you've got to think of this globally. I do. Okay, let's go forward. Okay, now you have the short, what is it? You have the short talar ligament. Really important. Why? When I do heel strike, I'm doing two things. I'm preventing forward motion, and I'm locking the hip and the knee. I'm doing three things. What muscle is engaged? The soleus muscle. After I hit, and the soleus is kind of like a monophasic muscle. It only does one thing. And when does it do it? On heel strike. So heel strike, I'm engaging in the soleus muscle, and the soleus muscle wraps around to the tuberosity of the calcaneus. And there's a nerve there called Baxter's nerve. So a lot of heel pain is caused by irritation of the Baxter's nerve. So, and by treating the short plantar ligament, you now solve that problem. Why? Because you're compressing the heel into the mid-tarsal joint. So when you're coming from heel strike to midstand, you're not flopping. So that's an important ligament to treat, and it's easy to treat. The long plantar muscle is, once again, starts at the heel and goes to the metatarsal. But it depends on the mid-tarsal ligaments to stabilize it. It can't do it itself. Another blessing for us. Go ahead. And there are two ways of approaching this. My way and everybody else's way. Now, the difference is I always come from the medial. Why not the plantar, which would be easier? Because there was a lawsuit in North Carolina where a young doctor had taken a course for, God knows, 1 or 2 days, and the person who was teaching him how to do it went through the plantar. What else runs on the plantar? The nerve, the plantar nerve. And he used a 16-gauge needle, and he was able to bisect the nerve. Obviously. Obvious. And then the next guy went and did something else, to fix it, which obviously made it worse. And he got sued. They got sued. They came to me to be an expert witness for him. I said, I can't be an expert witness because what he did, I think, is wrong. So the safest treatment, which I'll teach you tomorrow, is to go from the medial. And remember, the nerve runs on between the second and third layer, and you're on the fourth layer, or the first layer. Therefore, you're so far away from the nerve, you're totally safe. Totally safe. And you should be on bone, okay? And there you are. You see the nerve in red? You see how far away you are? You're a mile away from it. That's why I come from the medial. If you come from the plantar, you don't really know, and your luck will be that you'll hit the nerve. And that's not what you want to do. That's not what the patient wants you to do, okay? So where do I find the gateway? I use my 2 fingers, and when I use my 2 fingers, I'll be right at the gateway of where I want to inject. It's between the talus and the navicular. There's a nice hole there. You can follow it and hit the cuboid ligament, boom, right on, okay? Here I do everything else, and you see the cuboid. That is the atlas of the foot. The cuboid bone is the atlas of the foot. If you don't get that, you've done nothing. Nothing will work without getting the cuboid back into place, my thumb, and getting the ligament strong. Because what runs at the cuboid, anybody? The peroneus longus. Where does the peroneus longus end? At the knee joint. What is the extension of the peroneus longus? The tensor fascia lata. Where does the tensor fascia lata end? The lateral hip joint. Where does the lateral hip joint end? The gluteus maximus. Where does the gluteus maximus end? The iliolumbar ligament. Whoa. Okay, so go treat your iliolumbar ligament. Do what you want. Forget the foot. It doesn't mean anything. You're not going to be successful. Okay? So here, go ahead, John. There's a movie somewhere here. Technical difficulties. You notice the red injection. Most of it I'll show you tomorrow in clinic. It works really well. Okay, maybe the next slide. Okay. Say what? Okay, so maybe it got lost. Okay. So anyway, so now we have a couple questions. Let's go to the last one, please. Forget that. Okay, so one of the things we have to do is after we inject and the foot is relaxed, you have no muscle tension on it because it's anesthetized. You want to manipulate it. You want to get every joint back in place, and then you want to partially immobilize it, taping. And I use orthotics. And can you go back one? This is where the fibula, this is where the cuboid is. This is where you'll get your arthritic thumb from. The chiropractors in America has an activator, which I should have used, but I didn't. And if you cross it, and you'll know that's where you're going to inject. So it's an easy thing to do, and you manipulate it, which I'll teach you tomorrow. Go ahead. And I put the talus back in place. Okay. Charles Scott Sherrington, 1906. The nerve that transmits sensory information from the skin often controls the muscle below. Same story as Hilton. I thought Hilton was more thing, but everybody put their names to things. That means that if you can affect the skin above the joint, you'll also affect the joint below. And now you'll see me taping. By the way, my wife used to dress me, so I always had everything matched. And now I'm putting tape on, which I'll teach you tomorrow. Very simple. Put the foot in subtalar neutral. Paper tape. 1.5 inch paper tape. There's no tension at all on it. no wrinkles either. And they can get this wet in the bathtub or the shower. And I'm done. Go ahead, Jonathan. Same story. Let's move on. That's what it looks like before. I used the pad. Why? Not to hold the arch up, but to give the skin a signal that that's as far as I want it to go. I don't want it to go beyond that point. And the tape does that. The pad does that. Okay. That was what it looks like afterwards. Now, some gems. This I made after I heard Bjorn's speech yesterday. And this is not in your thing. Actually, when it got transmitted by way of the electronics, it kind of got screwed up. So if you'll take I can give you a thumb drive of it, you can do it. Now, the posterior ankle joint is equal to the posterior hip. So if you have a posterior hip issue, go look at the posterior ankle joint. The medial deltoid is equal to the medial knee. So if you have a knee issue where the ligament, the external ligament of the knee, the medial collateral ligament of the knee is issue, go look at the deltoid ligament. I'm not saying that it will always be there. It'll be there a lot. The mid-tarsal ligament, L3 and L4, and if any of you practice Chinese medicine, you know where the acupuncture points are in the foot. In foot reflexology, they always talk of the lumbar being in the middle of the foot. That is correct. You treat the ligaments there, the back tends to get better. Posterior plantar cuboid ligament is your tensor fascia lata and your lateral hip. Also, most important, check your leg length. I really believe in leg length. The posterior tibial muscle is your posterior knee. Where does the posterior tibial end? It ends in the middle of the foot. So if you treat the middle of the foot, you will treat the middle, you'll treat the knee, the posterior knee. The hallux valgus is, why do we have a hallux valgus? One of the reasons could be the body's trying to get rid of the height. So it's going to roll inwards, it's going to pronate more, which will end up causing the big toe to move out, which will then cause the toe itself to move in to balance it, and you have a bunion. So look at that. That should be a clue to long leg, short leg. Then when you look, and this was wrong, when you look at the acupuncture point, what's the acupuncture point for the neck? The bottom of the big toe. Why? You're walking. Once again, I talked about phases of gait. When I'm at toe off, where is my neck? My neck is forward. It has to be forward, and it's forward unilaterally. So what happens then? It puts stresses on my neck. Now, yesterday Bjorn showed you how to look at the toe. The toe bends only one way. It bends up. So if I have a limitation of bending up, I'm going to have neck problem. It's called hallux limited. So when you look at the toe, and you do what Bjorn taught you to do yesterday with the toe, your next question is, does your neck hurt you? And guarantee you, they'll say, yeah. So and I don't have an answer for that treatment, but whatever it is, just be aware there are treatments, very simple treatment for that neck problem. If you don't do that, how good is your neck treatment going to be? And how long is it going to last? Can't help you. Okay, I spelled Elios wrong. That requires what? When you see that, that requires you to do core exercises. So when you see a child that is kind of loose in the goose, what do you want to tell their parents to do? That child needs to learn core balance exercises. Weightlifting, and it doesn't have to be very thin, Pilates, whatever they do, riding a bicycle, swimming, anything they do for core balance is good. High arches, and that's another lecture between Heidi Lois. High arch people, women, generally should wear high heel shoes. Because if not, they're straining their back. So patients would come to me with these ugly shoes, or you see a lot of young kids now wearing flats, and I look at their feet and I said, boy, are they going to pay for this later? They need to wear shoes with heel. How high are the heel? There's ways of testing it using applied kinesiology, so you can see if it works. But they need to wear heels. My wife always wore heels. I'm the lowest, she was the Heidi. High arch feet also will get frontal headaches. So if any of you do craniosacral, you'll always find the issue here and here in craniosacral. Important. The more you know, the more you know. The more you see. If you don't know it, you don't see it. Very simple. Okay. Now, ethyl alcohol spray that Bjorn talked about yesterday. Let me tell you a little story, and then we're near the end. Ethyl alcohol spray, a friend of mine, we used to call him ethyl alcohol, ruined one of his eyes. How did he do it? The klutz squeezed the bottle when it was pointing up, and it hit him right in the eye. It froze his eye. Not a good thing. Let me show you an easier way. Go ahead. Oops, it didn't come in. Or did it? No, didn't come in. An ice cube. Cheap, easy. All you do is you put an ice cube where you're going to inject, be it the back, the neck. What does it do? It numbs the skin. And when the patient sees that, an ice cube. Great. Cool. You can inject, no pain whatsoever. Don't spend the money on the ethyl alcohol. Use an ice cube. Period. Simple and cheap. Only if you're worried about money. If I worked for a hospital where it wasn't my money, that would be a different story. But when I worked for myself, every penny counted. And I used, the ice cube. That ice cube, by the way, came last night from the table. Oh, I didn't see that. Okay. Why is the foot influence important? Because it influences the entire body. That's the way we address the ground. If you don't address the ground, you're either a porpoise or you're an arthritic. Now, what animal or what mammal does not have arthritis? Balance? Bats? Bats. Oh, I don't know. I never looked at a bat. No. Whales, fish do not have arthritis. Why? They're in neutral balance. They have no gravity, for God's sakes. No, they can't get arthritis. They don't live long enough. But okay. Which bones influence the foot the most? Two of them. The talus and the cuboid. Those are your two bones. The third one would be your big toe. But the big toe is going to influence your neck, which is going to influence your vision, which is going to influence your balance, which is going to make the whole issue go. What are the action of the plantar fascia? It's two actions. One, it pulls your heel off the ground so you can move forward. And two, it stabilizes your body on the ground when I'm in 1 foot stance. Learn your 7 stations of gait. Important. And I'll tell you one more thing. I think I told it to Bjorn. I know when you guys tell me it's a hip flexor, a hip rotator, blah, 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 blah. Oh, no. I'm only interested in one thing. What is that muscle doing in stance? You're in stance 60% of the time. You're in swing 40% of the time. Who cares what that muscle's doing in stance, in swing? Nothing to do with anything. In stance, that's where it makes a difference. So when you're talking about muscles such as the piriformis, what does the piriformis really do? Well, it locks the sacrum or the femur when I'm in the stance phase. That's the piriformis. I don't care for the hip rotator. Doesn't mean anything to me because it's not involved in stance. Okay. The best approach, I told you, is not from the plantar, but from the medial. What type of shoes, foot function? If I'm a low arch foot, wear anything I want to wear. I don't really care. If I have a high arch, I want to wear a heel. Why the heel? Because of the gastroc. The gastroc is the ischium. The ischium is the iliolumbar ligament. I think it makes it different. What are some exercises you can prescribe? Core exercises. Most important one you can do. Name some of the post-injection advice to patients. Don't take aspirin for 2 or 3 days. Take acetaminophen. Take Tylenol. You'll do fine. Any other questions you would like to add? Got a bunch of geniuses. Okay, if that's the case, next. Thank you all for helping. I don't know what happened here. I live in Israel. Anytime you want to come to Israel, please call me. I'm always available. I have a big apartment. You're welcome to stay with me. Frederick came and stayed with me, and we always have a good time. So there's a lot to say. Yes, you're coming? Wait till after the war, then we'll come. Okay, yes.
Okay. Thank you, Dr. Lenny, for the amazing lectures. I don't know if it is related with your lecture or not, but I want to ask about your opinion about barefoot movement.
Good question. Barefoot movement. The question should have been, at what age should children start wearing shoes? The answer is as late as possible. What should they do? They should run on grass. They should run on ground. And shoes are to me, a hindrance to your body movement. It restricts what you're doing. You also lose contact with the energy coming from the ground to the rest of your body. Once again, different mind, changed my thoughts. But children should not wear shoes, even those crazy little shoes they're wearing, except the parents love them. They have them bronze or whatever. But they should not be wearing shoes until they can run. Why? They need their toes to move. That's a very good question, by the way. Thank you. Any other questions that I can answer? Okay. Thank you.
Okay.
Thank you all.
Thank you.
Thank you.
It's about lunchtime. Lunchtime. Lunchtime.
Oh, lunch.
Okay. So we come back at 1:30, just as a schedule. Okay. So somebody cancel the Tuesday's workshop. So if you want to come through for the Tuesday's workshop, you can call us. Make some seat. Okay. So let's go for lunch and come back at 1:30. Okay.
好，那大家在听我这边好，那个我们的午餐已经来了，然后在这个走廊往电梯的方向走右转的餐厅，天空之城，曾经的城，那个餐厅天空之城，那我们直接在那边想那个吃午饭就好了。好，那
周二的讲一下
哦，那我们周二的那个工作坊啊，workshop还有名额，所以如果你想报名的话，那个连结还是可以报名的。好，所以如果想参加的话，尽快报名。The lunch is in the restaurant, just on the corridor. You just go straight to the corridor and turn right. Yeah.
嘿嘿嘿，一二三，嘿嘿，回来飞，一二三，嘿嘿。
说这麦克风是我们的，对啊，这麦克风是我们的。
对，这个配合是我，但是麦克风，你们的配合我已经放在那边，就你们。
你说这个是可以拆开的？
对啊，
哦，
因为我的是免的，我刚好喜欢用免好的。
1、2、3，1、2、3，测试测试，可以可以，喂喂，1、2、3，1、2、3，好
1、2、3，嘿嘿嘿嘿嘿，喂喂喂，1、2、3。嘿嘿，喂喂，1、2、3，嘿嘿，嘿嘿，喂喂，喂喂，嘿嘿，喂喂，嘿嘿，喂喂，嘿嘿。喂喂喂喂，嘿嘿，1、2、3。
you know in Terminator 2 Judgment Day, Dave Cameron revealed in the DVD he didn't inform Schwarzenegger beforehand. T-800 didn't kill anyone. When filming, Cameron told Arnold T-800 would which Arnold didn't. Consistent. Believing the film was flop if T-800 wasn't. Whether they took out again. Okay. So.
Okay, you're in charge of my voice, all right? Okay. we have to give him a responsibility. You can put it in my pocket or wherever it goes. Oh, this is perfect. I guess I'll be introduced first, but no, I look forward to this. What, darling? No, I'll go with the slides. Yeah.
Double check.
Yeah. Oh, yeah, you're. Thank you, darling. I love you. Hold on. I can't go. Yes. The shoulder, yeah.
Still wait a minute because somebody still have lunch. Yeah, so we wait for somebody.
So we know which one to.
Yes, it'll be the knee and then.
沈楼，那个外面还有人吗？可以进来喽。
OK，
可以进来喽，准备哦，要准备上课喽。
Do I click it or do you? Okay.
Okay.
All right. Thank you.
Wait. Okay, we got a surprise for you.
We got a surprise special guest.
Yeah, it's our grandpa or my brother. so it's family union here. So yeah, so this afternoon Stanley will be here together with us and be the moderator. So also share some the history of Hong Kong, Taiwan, and between AOM for us. Okay. So let's give time for Stanley.
Good afternoon. So immediately after your lunchtime, I think it's time for me to. I don't have to introduce the speaker. That's why I just like to share with you the history and the story and the road of my learning about prolotherapy and why you have to learn all the knowledge and the skills taught by our grandfather Lenny and beyond. Yeah, these are so important. In fact, I met Lenny in 2002 in Colorado Springs or in Denver in the snowy days. And then there's in a hotel. And at that time, apart from Lenny, was also Tom Raven and also Mark Cartieri. And at that time, I didn't know what I was learning. Completely didn't know. My brain was just completely empty, and I know nothing. So you guys are very, very lucky, and you guys are fortunate because you already have a lot of the background knowledge to start with. I think these are so blessed. And then also I met Dr. Beyond here back to 2005 in AOM. At that time, I met Lenny was AAMM. In fact, it's not AOM. Okay, and that's how I started. Then at that time, I was stressed. Biomechanics, and you have to treat the whole person. Very important. You have to look at the patient. Even the low E and the high D from Dr. Lenny, I still remember that. I know nothing about that at that time. And then I just get the concept. I have to look at the whole person. Each time when the patient comes into your office, you have to look at the patient, how he or she walks inside your clinic, and then you decide. And then those are the experience and knowledge you're going to accumulate. And I still remember in Colorado Springs, I met Dr. Beyond here in a consultation room, and that's a conference room. And then it's already the AOM's annual meeting, and it's a group group tutorial. And then Dr. Beyond at that time said to us about the holistic approach of prolotherapy. You have to inject, you have to inject the right target, not only inject one part. For example, a patient comes to see you with a knee OA. Don't only look at the knee. You have to look at the hip, the lower back, the foot, and you have to look at the whole person. And that's the reason why you need to learn comprehensively. Why you need to learn all these things from this grandfather of prolotherapy. It's so important. And then throughout the years, I accumulated many different skills, knowledge, ultrasound, but my thinking is still the same. You have to treat the root cause. Don't only treat the consequences. If the patient presented with low back pain, presented with neck pain, presented with shoulder pain, presented with supraspinatus tear, that's the consequences only. Root causes are something else. So you need to back to the very important thing is to taking history. Dr. Beyond was stressing that at the time, taking the history, what really happened at the time the patient developed the problems. Very important. So it took me several years to understand all this. And even nowadays, I'm using ultrasound-guided injections. My thinking is still the same. Don't treat the consequences. You have to treat that to ease patient's pain, but at the same time, you have to treat the root causes. I think I won't take a long time from Dr. Beyond, but I really want you to know why we can fix patient's problem better. Just now, during lunchtime, we were discussing about how you can use the bullet, which you think is the dextrose, the PRP, you think is the bump, and the so-called the bone marrow aspirate, which probably is the nuclear weapon. Okay, so whether you want to use that to hit your enemy, I think the best way is to use one bullet to kill the general. You use one bullet to kill the general, and in fact, the whole army just collapsed. So I think the best way is to find the root cause, treat the root cause, and then you will get results from that. No matter you're using dextrose or using PRP or so-called the other stronger solutions, but you have to hit the right target. So I'll give the time to.
Thank you. Thank you very much. Thank you, John. Before we start, I'd like to talk to you for a few minutes. I was delighted to listen to Lenny today. He had so much knowledge to give, and I was just delighted to see how he presented it. It is very hard to absorb it all. Thank goodness you have his notes. But this is the issue here. When you see a patient, the first thing when the patient comes into you, you are observing. You're observing gait. You're observing how they sit. You're observing how they move. And then they will come to you with a specific complaint. It may be mild. It may be severe. But then always get a good history, as good as you can, and do a good physical examination. And don't just focus solely on the problem, but you focus on the entire person. And you'll find in the future, because you're all family physicians, you're not only going to look at the immediate problem and treat that, but you're going to treat the person. If they come to you and they want your help, you'll observe and make recommendations for posture, for fitness, and for nutrition, and then the metabolic side. The metabolic side is extremely important. Now, most people are going to be balanced. You don't worry. But you have to pick up those people who have aberrant hormones or who are overly inflamed. Because when you have inflammation or, let's say, too much sugar, etc., you're not going to get the end result. And you will know when you start treating a person, every time you look, you observe, are they getting better or are they complaining about this and that? And then you'll know that you have to expand your approach to treat. Now, Yesterday when I spoke, I spoke about one thing that I'm going to repeat it because this to me is extremely important. When you look at whatever body part you have, whatever body part, you think fibroperiosteal junction, the attachment of a tendon, ligament, and so forth to bone. You think of micro or macro tears within the joint capsule, the ligament, or tendon. These are all possibilities. I'm going to show you how this works with the shoulder, because we'll focus on the shoulder. And then you look at entrapment of unmyelinated nerve fibers, C fibers. These are sensory fibers that are sympathetic. They can manifest themselves as a trigger point or as a tense muscle bundle in that area that you're trying to treat. And if you're not aware of it, you will miss it. Before we get started, I want to show you these things I've come across. It's not immediately. I learned by trial and error over many years. I've been practicing prolotherapy since 1982. And when I started, I didn't know. I had been an orthopedic surgeon in the United States Navy for several years, and we treated fractures. We treated shoulder and knee injuries in young sailors and Marines. And we looked at the patient, we just looked at the knee, and we said to ourselves, is it surgical or not? And then we would say, if it's not, we sent them to physical therapy and so forth, and it trusted that they would get better. I look back on that period. I want you all to remember this. We did much surgery. We were stationed in the Philippines at Subic Naval Base. Today, with knowing orthopedic medicine, today, I would have done less than 50% of the surgeries that we did for the knee and the shoulder. Less than 50%. To me, looking back on it, I said, where was I? I didn't know. We had training that was specific for what we did at that time. Now, each one of you are in practice. Each one of you will see patients of varying degree. And I want you to know that as long as you practice, you will always be learning. Every patient you see can give you another lesson how to do something better. And you want to be able to do that. If you do that, you'll find with time, you will be very happy that you're able to contribute so much more to the patients who come to see you. Now, I want to get started on this, but when we go over this, I'm going to remind you of the fibroperiosteal junction, micro tears, macro tears, because I don't think any of you have really paid attention to it, because no one told you. This is the key to the shoulder. I've been told by several people that the shoulder joint is very difficult to treat. It is hypermobile, and we treat it. If they get better, they don't get better. And I had the same feeling. Now, I think I know how to treat it effectively, and I want to share that with you, so it'll be better. Next. Now, the shoulder girdle. Certainly, when you look at the shoulder, you don't just look at the shoulder joint, you look at the entire shoulder. Sternoclavicular joint, acromioclavicular joint, the glenohumeral joint, also called the shoulder or scapulohumeral joint, and we call it the acromiohumeral joint. That's the space between the acromion and the head of humerus. Now, bones, clavicle, scapula, and humerus, and muscles supporting stability and movement. Next. This is just a picture to show you all the muscles that surround the shoulder and the bone. What do you see most significantly here? You see how large the head of the humerus is related to the glenoid fossa. This is critical, and this is what causes most of the problems in the next year. Now, muscles of the shoulder girdle. Each muscle has a distinct function and range of motion. The joint capsule and supporting muscles are responsible for shoulder stability. Resistance at passive end motion will often identify the site of pathology. I will demonstrate that to you, and you do this by feel. Now, rotator cuff, certainly subscapularis, supraspinatus, infraspinatus, but that's not all. A major muscle is a long head of the biceps, brachii, and a lesser, but also important, a long head of the triceps, but you have to be aware of it, you have to see it. Next. This is a picture of the shoulder. You see the deltoid anteriorly in the pectoralis major. On the other side, you see the pectoralis minor. It's a little hard to know how that relates, but there's a way of identifying it. But this will be, you have to do this clinically. Every time I've seen an anterior shoulder injury, automatically we look at the joint capsule, the immediate rotator cuff, which would be the supraspinatus and infraspinatus. Yes. Very importantly, if it's an anterior shoulder problem, you must look at the anterior head of the deltoid muscle. Or you have to look at the pectoralis major muscle. It can be the clavicular head, the sternal head, or the abdominal head. And you observe. You observe for swelling over the shoulder, and it's usually very subtle. But once your eyes begin to look at it, you will notice it. Next. Posterior shoulder muscles. The same thing with the posterior deltoid, the infraspinatus. These are major muscles that go into protective spasm when the shoulder joint has been injured. But if it becomes prolonged, those muscles become a problem unto themselves, and they limit range of motion. Next here. Can you hear me all right? I don't know what it is. Thank you. I need your help. Okay. Thank you. Here is a typical rotator cuff. And you look at the subscapularis, supraspinatus, and infraspinatus. But on the left, this long head of the biceps, as it passes through here, is a major cause of anterior shoulder pain. Not the tendon itself, but the transverse humeral ligament and the coracohumeral ligament. When you look at it, we'll see more. But this is major. And this is the cause of a large number of patients who come to you with anterior shoulder pain. Next. Shoulder motions. Flexion, extension, abduction, etc. Now, these are the ranges of motion. Flexion can go up to 180, but rarely, usually 150 to 180. It depends if you're male, female, young, or old. Extension, 35 to 50, and that is usually normal. Abduction, neutral to 90. However, abduction in men is much less than women. You're lucky to get 70, but I will show you. You feel the end motion, and that tells you if there's a problem with that muscle or group of muscles. Now, here is it down below is elevation. This is pure humeral, not pure, but nearly pure glenohumeral motion. From here to here, scapulothoracic rotation. Then the last several degrees will be abduction. You have to be aware of that when you look, because it'll tell you oftentimes what the problem is. adduction, lateral rotation, medial rotation. We'll go through all of these next. When you're examining a person, you always do horizontal flexion, horizontal extension, horizontal adduction, abduction. You say, why? A lot of people don't do it. If you come up and bring your arm here, and they can do it actively or you do it passively. If this is limited as compared to this, it goes down and this only goes this way, you know that the deltoid muscle at the attachment to the acromion is at fault, usually with inflammation of the underlying subdeltoid muscle when you do this. When you go back like this, and you can feel it, you're now tensing the pectoralis major and deltoid over the head of the humerus, and it'll tell you if you have pain here. Then you do horizontal adduction and abduction, and you get a feel for it. And then that will often tell you what to look for. Now, next. Always think of muscles that support scapular stability. And the serratus anterior usually is not a problem. But if it is, and the motion doesn't seem right to you, you look at all of these muscles, trapezius, levator scapulae, rhomboidus major, minor, serratus, pectoralis minor, and so forth, that could be contributing to scapular dysfunction. Next. Sternoclavicular joint. Always look when a patient comes to you who's been in an auto accident or something of that sort. I've seen in my practice over many years people who come to me after an auto accident, usually some time ago. And the first thing you do is you just look at the patient. And you don't go, oh, let's look at your shoulders. No. You look at the total person, and you scan the sternoclavicular joint. In a number of cases, I've seen anterior subluxation of the sternoclavicular joint, and not one person recognized it. What? Because they didn't look. They were not aware. But you here will always be aware when you see a person with a shoulder issue, you look. You've always checked the sternoclavicular joint, the clavicle, and then the acromioclavicular joints. And that's easy to do. Now, common disorders are acute or chronic strain. You'll identify that by tenderness or anterior subluxation. Wonderful treatment, prolotherapy. You may have to do it 2 or 3 times, but that will work. And what you want to do is improve posture, because this takes, when you bring the chest out, the clavicles are pulled a little bit laterally, and it causes those joints to become less stressed or more functional. Next. Clavicle, yes. The costoklavicular ligament can be a problem, especially if there's a major subluxation. Usually not. Then you look at the subclavius. That can be a factor, but you have to look for it. If it's tender, it's usually at the origin. Now, this just shows you the clavicles. Now, on this side, you have dislocations of the clavicle, grade 1, 2, and 3. Now, sometimes, if you see the patient, you may say this person needs a surgical intervention to tie down the clavicle. But in grade 1 and 2, let me tell you, you can treat them with prolotherapy in a large number of cases. Fractures of the lateral third of the clavicle. If it's, you would tape the clavicle downward and use prolotherapy in the fracture site. You can do this, and this is simple. You can do this in office as you follow them. All right. Should I have a pointer? Yeah, oh, good. Thank you. When there is a major fracture here, and it's in a female, and the fracture is like this, if possible, women, more than men, would like to have the clavicle in alignment, even if there's a scar, because it looks better. When we were in the military and we saw major fractures in the middle third of the clavicle, we just put them in a sling. Hey, you'll get better. If you have a big bump there, it's okay as long as it's stable. That was the attitude. But always keep that in mind. Next year. Acromioclavicular joint. The common disorders are acute or chronic strain, subluxation with instability, or arthrosis with or without bone spur. Now, I've seen many of these patients, and unless there's a bone spur that needs to be removed, prolotherapy is a treatment of choice, both not only for the joint capsule and the ligaments about it, but also for the coracoclavicular ligaments, trapezoid and conoid. But that's all. Sometimes you need to have the coracohumeral ligament. I don't see that as being a problem in most of the patients that I've seen. But this is what you want to look at. And if you can stabilize that joint, so in all the movements the joint is stable, it will probably be with pain less. Now, sometimes you have to just inject the joint a few times, again, dextrose, and that'll help make the joint painless. Next. This is just another picture showing you the extent of the AC joint here. Next. Now, the glenohumeral and acromioclavicular joints. Again, take a look here, how small the glenoid fossa is versus the humeral head here. Now, you can't see it, but right here, you'll see more in another picture. This is a key to understanding what happens to the shoulder and how to treat the shoulder effectively. Now, certainly this, you're going to find at the end of this talk is major here. Then also the joint capsule here and the overlying muscles. Next. They're remarkable for freedom of motion while retaining a basic structure of a ball and socket joint. The flat, small area of the glenoid fossa contracts and amounts to only 2/5 of that of the humeral head with which it articulates. The capsule of the glenohumeral joint is composed of 2 systems, the one anterior and the other posterior, united superiorly by the coracohumeral ligament, which can be a major ligament in certain injuries. The coracohumeral ligament surrounds the tendon with the long head of the biceps becoming continuous with the transverse humeral ligament. This is a key area of the shoulder, and this most people don't understand, but this accounts for a huge number of chronic shoulder problems. The coracohumeral and transverse humeral are responsible for maintaining the long head of the biceps, breaking muscle into the bicipital groove as it continues to the supraglenoid tuberosity and superior joint capsule. Now, the central element of the shoulder complex is the scapula, adapted to articulate accurately with conveying the thoracic cage. Why is this important? You see people coming like this. If they're old and they've been this way their entire life, that's the way it's going to be. You see a young person like this, boy, posture becomes a major issue. Well, here again, glenohumeral joint, abduction to 90 degrees, thoracoScapular motion 50 to 140 degrees, and adduction about 140 to 180. The joint capsule is strong but mobile, particularly posteriorly and inferiorly. Next. Again, the glenohumeral joint. Now, where do you get injuries in this joint? The articular capsule, certainly. Glenoidal labrum, yes. Coracohumeral ligament, but I'll go over these with you and show you. All of these ligaments can be injured. You have to look for every one in your mind when you see. When you're looking at the shoulder, what can be causing your problem? Next. This is the problem. This is the humeral head, and this is the glenoid fossa. I want you to do something now. All of you stand. Stand up. I want you to look at me, and I want you to do what I do. You put your left hand on your right anterior shoulder. Now you bring the forearm into the abdomen and put it right here. Now bring it out. And you're going to feel the anterior margin of the humeral head being restrained by the anterior joint capsule. Now, come back. Put your hand, if you can, behind. Here. And then when you bring it in this area, you're going to feel the posterior margin of the humeral head being restrained by the posterior joint capsule. Okay, thank you. I want you to all do that. Why? Why? In nearly every sporting injury in young people that I see, there are three issues, either posterior shoulder pain, anterior shoulder pain, and sometimes lateral pain. In anterior shoulder pain, the first thing you look at are micro, or you're thinking now, micro or macro tears in the anterior joint capsule, right here where the humeral head is nearly every time. And when you feel that, you place the needle there and you direct it slowly, and you're right next to the joint capsule, to the glenoid rim. Now, that is a major cause of anterior shoulder pain. When it is the joint capsule here, you can be assured that the pectoralis major, as it passes over the humeral head, goes into protective spasm, and in many cases can become a source of pain here. When people throw balls like this and they complain of severe pain here, the first thing you look at is the area of the joint capsule where the humeral head is being restrained. Then you look at the overlying deltoid muscle, sometimes the infraspinatus. And you find out now you not only have a joint capsule or ligament problem anteriorly or posteriorly. We'll continue. This is why this is so important. Now, next one, next year. Now, this is an inferior glenohumeral. This is very strong, and this is very important because there's a fold. We'll show in another picture, I hope. And oftentimes, if you hold the arm like this, you get adhesions in the fold. And the arm cannot go, when you go up like this, the humeral head is supposed to drop down, and it can't. If you have to be aware of that. Next. Here's the fold. You always have to be aware of this. Again, you see this rather large humeral head, and you see this space in here. Next. I'm going to go over this briefly. We've talked about this before, but I just want you to think again. We'll just go over fibroperiosteal junction injury, micro or microscopic failure begins to occur after it's having a greater, but let's see, I'm trying to look at it. Macroscopic failure begins. These are micro or macro tears here. Always have that in mind, because when you see patients, you're going to look at the fibroperiosteal junction, which Lenny talked about, then you're going to be looking at tears within the joint capsule, anteriorly or posteriorly, and this is going to direct your treatment. And nerve injury, certainly. But this occurs oftentimes in the supporting muscles. Next. Now, we've gone over this before, the periosteum, the superficial, and the deep layers. Next. Now, again, contributing factors. I'll briefly go over this because this is really important. One is hypermobility syndrome, Ehlers-Danlos, if very severe. Aging, certainly. Nutrition and digestion with protein deficiency. That can be major. So you want to talk to your patients to see, and you get an idea if they have good nutrition, etc. Hormonal imbalance, uncontrolled diabetes, hypothyroidism, adrenal exhaustion. All of these can be factors in preventing the patient from getting well. Thanks. Now, this is what you see in young people, boys or girls in their late teens or 20s. Anterior shoulder dislocations. Common. In the Navy, when we saw that, in the Navy, we would operate on them. At that time, we would take the tip of the coracoid process and we'd reimplant it into the anterior part of the glenoid, thinking that we had done a good job. Today, no way. Why? When you feel still and if you see this, the first thing you do is prolotherapy. And you start out, when you do prolotherapy, you start out at the mid portion of the joint capsule. And you hit the bone, you slide tangentially to it till you get to the glenoid rim. What are you doing? You know if the patient has suffered a joint dislocation, you know there are tears in the annulus. You know it. You can only identify it by pain patterns. And by if you move out, please don't do this. I'll give you an example of a patient that I saw a few years ago. 17-year-old boy. He wanted to be a wrestler. But his mother brought him here because both shoulders subluxed anteriorly every time he tried to be a wrestler. I looked, I said, oh my God, I don't know what to do about this. This was starting in March. He was going to college in October, in September, October. So every month we treated the anterior shoulder capsules and the posterior too. But the anterior was a major issue here. And then he went to college. I didn't hear from him. I saw the mother came to me later for another problem. Said, oh, my son is on the wrestling team. What? Yes, he has no shoulder problems at all. Now, there are two issues with this. One, obviously he had a weakness there. Why? I do not know. But his general health was very good. He was a fit fellow, strong, and working out in the gymnasium. I said, isn't this interesting? Now, anterior shoulder subluxations. You see that in men and women anteriorly. Again, treatment of choice, prolotherapy. And you might have to do several treatments, but it varies with people. Posterior shoulder subluxations are usually voluntary to people who are very hypermobile. And if it doesn't bother them, you tell them not to do it. Posterior shoulder dislocation is extremely rare. I've never seen one in my career. Next. Now, there are 8 conditions that cause most shoulder pain. 8 conditions? Be more or less, but this is what I see. Now, sprain of the transverse humeral ligament and often the coracohumeral ligament controlling movement of the tendon of the long head of the biceps. Injury occurs at the fibroperiosteal junctions of the margins of the bicipital groove. Strain of the anterior head of the deltoid muscle and sometimes the lateral head of the deltoid muscle are attached with the subscapularis. I don't want any one of you to forget this. This is the most common cause of upper shoulder area pain. Injury to this, and I'll show you in other pictures how this comes about. If you remember that, you'd use a very small needle, That's why I use prolotherapy. And you have to identify by palpation. If you have ultrasound, you probably can do it. But you inject the attachment sites of the transverse humeral ligament primarily. You move upward onto the head of the humerus and to get the thoracohumeral ligament. And you look for areas of tenderness because there will be micro and macro tears in that area. I will promise you this is the #1 cause of upper anterior shoulder pain. Along with that, you're going to find that the anterior head of the deltoid, sometimes the lateral head, will be swollen. And if you stretch the arm out like this, put stress on those muscles, you'll feel tender muscle bundles throughout. When you treat that problem, the transverse humeral ligament, thoracohumeral ligament, you take a 30 gauge needle, ½ inch or 1 inch, with just local anesthetic. You could add a little bit of dextrose, and you inject. If you use a ½ inch, you just inject subcutaneously. Remember what Lenny said: skin, muscle, joint. Sometimes you only have to do the skin. Sometimes if you see muscle bundles, you place a needle into the bundle, and you move. You then test the patient afterward. And I've had a patient that came to me after 2 years of frozen shoulder syndrome. I thought I would have to manipulate the shoulder. Not the case. I started with prolotherapy. I did one treatment and said, this is not your problem. All I used was 5% dextrose, 0.5% lidocaine, with a half inch needle and a 1 inch needle. And I went from the anterior lateral to posterior. It took several months and maybe 4 treatments. We saw him every 2 to 3 months. At the end of that, remember, he had 4 years of having a frozen shoulder. He had full range of motion. It's not simple. When you come there, you inject in. This fellow told me, oh, you missed this, you missed that, etc. So you'll go back until you get everything. Now, by combining prolotherapy and this, you'll have a lot of control. Next, pain. Oh, there it is. I'm trying. Well, it's pain in the middle and lower portions of the shoulder joint. It's what I told you. The tear is primary, or the injury is primarily anteriorly, and you can feel exactly where it is. And these are micro tears within the capsule that can extend all the way down to the glenoid rim. If you identify that, you put the pain, and you put it under stress, so you know where you are, and you take the needle, hit the bone, or if you will, or the head of the human, and you go tangentially downward. Nearly universally, you're going to find that the pectoralis major muscle overlying the humeral head is contracted and tender. You'll feel muscle bundles. Then you use neural therapy, and you'll find after a few treatments, the patient should get markedly better. Next. Posterior shoulder joint is the same. You see this in people who are golfers, who throw balls like this. I'll show you. Young man, he's 6'5", and a football player. He was going to Cornell as a quarterback. He did this for a year. He had severe posterior shoulder pain. His father graduated from USC, so he went to the orthopedic department at USC. 3 orthopedic surgeons assessed him. 3. They used local anesthetic in various sites, and at the end of that, they did not know where his pain was coming from. Did not know. What? I saw him briefly before he went back to school. There were micro tears in the posterior joint capsule right at the level of the humeral head margin. And I say, well, isn't this interesting? Because what I'm telling you now, most people do not know. They do not understand. But if you remember this, you'll find in your practices that you'll do very well. You'll find very, very much so. Now, maybe I wear out the lateral shoulder joint pain. Here, lateral. That's rotator cuff. Can be supraspinatus at the superior facet, the infraspinatus at the middle, and the teres minor at the posterior facet. Can be 1 or 3. Now, when you see that, the injury commonly, oh good, remember this. The injury to the supraspinatus and infraspinatus muscles are usually the lateral margin of the facet joints that they become attached to. And even if you have minor tears, but has been separated dramatically, you can treat that and make it stronger with prolotherapy. Use a very small needle so you can be more accurate by the way you're treating. Now, when you see pain here laterally, just don't say it's rotator cuff and focus. Don't. You think lateral deltoid. Then you go and you take the needle along the margin of the acromion at the attachment. If you place the needle underneath the rim of the acromion, what are you going to feel? You're going to feel this subdeltoid bursa. And if that is thickened, then you treat that as well. You can do it with prolotherapy, or you can just do local anesthetic with a dash of corticosteroid. Now, when you see it laterally, and you're talking about the lateral head of the deltoid or the deltoid tuberosity, you have to remember when the muscle comes over the greater tuberosity, it's tethered by fascia, especially anteriorly here. And that too can be a source of pain. Now, there are other conditions that you have to look at. But if you examine the patient carefully, Rayanne is going to come up, and I'm going to show you how I do it. I'm not telling you should do it, but we all have a way of identifying the problems. But first, you must identify the problem. Shoulder, sternoclavicular joint, acromioclavicular joint, and occasionally clavicle. Anterior shoulder, upper, lower, posterior shoulder, and that includes the glenoid too. And then you have lateral shoulder here. Now there are other injuries, but these are the common injuries. And if you know that, and you know what you're looking for, you can treat everybody very successfully. Very successful. With that comes exercise and graduated exercise. Remember, motion. But you don't do big. You don't go, going back with heavy weights. You just do motion alone, at least in the first week or so, or for a few weeks, because motion is going to help you with that healing. Next. Inferior shoulder, straighten the long head of the triceps brachii muscle. You don't see that often. But when you are examining and you get a sense that there's a problem at that level, and because when you're doing this and you have limitation, you know that the head of the humerus is not dropping down to allow full motion. You know that. Sometimes you have to put a needle with just local anesthetic, maybe 5% dextrose, into that recess. And you may have to do it and then stretch because you know the inferior glenohumeral ligament has contracted. You know that. Now, cervical thoracic spinal pain. When the patient complains of pain in the suprascapular area, there's a multitude of causes for that pain. Number one are the facet joints from cervical 5 to about cervical 3, 4. You palpate. If that be the case, then I would do just polo therapy. If the muscle is in the suprascapular area, which is basically the trapezius, and to a lesser degree, more anteriorly, the levator scapulae, neural therapy, you observe. Sometimes, if it's more lateral, you have to pick up the scalene muscles where they attach to the transverse processes of the lower cervical vertebra. You see, when you do this, and you see a patient, you want to test yourself. I test myself all the time. What structures are in the area that I am concerned about? Do that every time in your mind. It's just in your mind. And that'll keep you very, very alert. Now, we talked about the cervical thoracic spinal pain here, the acromioclavicular joint, and the acromioclavicular, and myofascial pain. This is the deltoid muscle, pectoralis major, infraspinatus, and supraspinatus. I've seen patients that have come in that have had long-term pain. And we had one recently, and a man who said, I can't lift my arm up like this. This is for 3 years. 3 years. You look, you didn't get an idea that the joint was. It was the muscles. Neural therapy. Local anesthetic in the muscles. When he left, we had full range. Obviously, you have to repeat it. You have to get him on an exercise program to maintain it. But this can be done. Here. This I want you all to pay attention to. Right here. The transverse humeral ligament. It's attached to the lateral bicipital groove and the medial here. This, when this is inflamed, when that is inflamed, it transfers to the tendon, then you get muscular pain all over the front. This is huge. And I don't think any of you have ever heard that. But now, none of you are allowed to forget it. This is going to be one of the best things that you can assess when you're looking at a patient. Now, here you have the coracohumeral ligament, which is a little bit more superior. Then, of course, you have the glenohumeral ligaments here, where you get the multitude of micro tears that go down to the glenoid rim. Very important. Next. Posteriorly, you have the same thing here, tears going down to the glenoid rim. Here you would say, you see all these muscles, but you identified by your hand. Palpation is going to tell you exactly where to go. Next. Now, look at this. This is a major and look where he's taped. Why is he taped there? Strain of the long head of the biceps brachii muscle as it passes through underneath the transverse humeral ligament in the bicipital groove here. I've seen many athletes, they have the same problem. Because look, when you bring your arm up and you're stretching the long head of the biceps, and you do that enough, and these are healthy people, they come in with pain. You look at baseball players here, and then posteriorly, they can be here. It depends upon what sports they do. Next. Now, my patient, he's 51. He is as fit as could be. He is so strong, being 5'10", and 178 pounds. He competes regularly in Masters tournaments. And for some reason, he loves this. But he comes to me after each major contest because everything has been injured. Now, I want you to look. Right shoulder, complete tear of the rotator cuff with retraction, complete tear of the long head of the biceps brachii muscle, left shoulder, partial tear of the long head of the biceps. Still a champion. I say, look, what? He can take a man in his contact and throw him over his shoulder. He can compete at the highest level. And look at the rewards he's done. So, I'm showing this to you. So you understand that if you have a rotator cuff tear and it's retracted, you can compensate if the patient is willing to put in the time to strengthen the deltoid, the pectoral muscles. It can be done. And sometimes you see patients that come to you many months after with complete retraction and they want help. I said, well, you reduce any residual pain and get them on an exercise program. And I look at, he's 51. I don't know when he's going to quit, but he keeps on going. Next. Now, examination of the shoulder group. I want to go over this just briefly, then I'm going to ask Ryan at one point here to show you what I do. You just observe. The patient is sitting in front of you. If it has shoulder pain, you'll ask them to take their shirt off, so you can look at the shoulder. All you do is look. You don't rush up and try to touch. Once you become familiar, you'll identify any swelling within the deltoid muscle anteriorly, laterally. You go behind and you look for very subtle signs of posterior deltoid swelling. That's the first thing you look for. You certainly look at the sternoclavicular joint and the acromioclavicular joint. You test the joints by palpation and to see if they're stable or painful. You look for suprascapular muscle tension and scapular elevation. You interscapular myofascial tension, usually over ribs 2 to 5. Forward head and neck posture, that can be a real problem. Accentuated upper thoracic spinal curve, a problem. Swelling, anterior subluxation of the sternoclavicular joint, muscle tension, swelling of the anterior deltoid, and so forth. You haven't even touched the patient, but you're looking. And the patient is telling you where I hurt. Now, active shoulder resisted trapezius and levator scapular muscles, C3-4, and spinal accessory nerve. Active adduction. Passive adduction, you do this. And you do it passively and see if there's any pain provoked in the upper thoracic spinal area. Next. Again, sternoclavicular joint. All you have to do is observe. See if there's swelling or anterior subluxation. Remember, I've seen a multitude of patients who've had this problem and seen doctors. No one ever looked. You will now look at this on a regular basis. The clavicle is usually not a problem because they're there. Acromioclavicular alignment, tendon stability, subluxation, evidence of O separation with bony rack, inferior bone spur. That's an X-ray. Now, anterior shoulder, superior facet or greater tuberosity at the superior. This is what you're looking for. Oh, I won't read everything. It's too much. Lateral shoulder, posterior. This is what you're looking for. You palpate slowly. You look. Next. Now, I like to look at active motions. I ask, how far can you bring your arm up? It means only to here. Okay. You do it in the scapular plane. You do it in the sagittal plane. You get an idea. You'll compare it, if necessary, you'll compare it with the opposite side and use one side as a guide. You go here to see about the anterior aspect of the shoulder. You see, you just do these things. An active extension, then passively you can do it later. But these give you an idea of what the problem is. Next. Now, I'm just trying to see here. Rayanne, can you come up here? What I want to show you. When you might want to test for strength first. It depends on how you do. Now, I'll ask her to push out here. Strong, you test both sides. What are you testing? The supraspinatus primarily. C5, and then you bring it up here. Deltoid muscle primarily, again C5. Then you push down. You're doing the pectoralis major, the latissimus dorsi, the teres major primarily, and also the pectoralis minor. Bring it down. Already in your mind, you're saying this is C6, 7, 8. Already you've had a good view of what's wrong. Now, you come up here, palm down. Strong, you'd expect it to be strong, but then you're looking at the scapula to see if there's any winging. That's the long thoracic nerve from C5, 6, 7. You already know that the muscle, that the nerves are numb. Now, if they complain of pain here, you've looked, you see swelling here. First thing you do, you bring palm down like this. You don't push here, you push here. Strong. Supraspinatus tendon. Now palm up. Up. Strong. And if this is strong, you test it here. What are we testing? The long head of the biceps brachii muscle. If that gives way here, you know you have a problem up here. You know that. Now, turn face that way. Then I come back. When you do this, you feel. You don't jump up, you feel. I know she's right-handed, and you're going to feel more tension. But if the tension is great and she says that hurts, you know you have an anterior capsular problem. You know that. Now, so we've done a long time. Then always this, 90 degrees. But if it's this way here, and she says I have, and you pull a little bit, there's pain, you know you have a problem here. And you're going to turn that way again. Turn that. Then if you know you're going to have a problem here. That's a joint capsule with the overlying pectoralis major and deltoid muscles. You see how you're bringing in everything into exactly what's wrong. Now, let's say we've done motor function. We've checked in passive motion. Then every movement means something. You go here, you don't just bring it out, you feel. You put your hand over the shoulder, you feel. Then when you come up and you're looking like this, I like to do it passively. I put my hand here. Once you learn, once you have a feel, you're going to know exactly where the problem is. Upper shoulder, anterior, inferior. You're going to know. Now she's normal, so nothing here. Look at. But you see, the passive movements are extremely important, and you just don't say it's limited. You say in your mind, where is it limited? Superior, posterior, anterior, and this allows you to figure out everything. Thank you, darling. Thank you. Now let's see. Where are we? Next, passive shoulder motions. Next, resisted treatment considerations. 1, improve posture. Exercise to toleration to improve muscular function and stability. Nutrition to support healing. Local anesthetic, and sometimes corticosteroids to reduce inflammation. If it's severely inflamed, and you have the ability to see the patient in a day or two, you can use corticosteroid and don't feel fearful of it. But when they come back, you will use prolotherapy to get started with treatment. Prolotherapy for connective tissues at the fibroperiosteal junction and joint capsule tears. Neurotherapy for trigger points in areas of myofascial strain. Muscle shortening causing entrapment of unmyelinated sepum. Not uncommon. If you don't recognize, if you're not aware of it, you're going to miss it. Possible shoulder joint injection to reduce synovial inflammation with dextrose, local anesthetic, and maybe corticosteroid, but mostly dextrose and local anesthetic, followed by ozone. Shoulder mobilization, if motion remains limited due to scar tissue. When there are adhesions that do not respond to your standard treatment with physical therapy, you can mobilize the shoulder in your office. You have to give the patient a degree of sedation. We would give them Demerol to start. We would inject the joint itself and the capsule around it. Then we would bring the arm up and over. And any adhesions that are resistant are usually right here, and you can break them. If you can, you then have to get them on a rehab program immediately, because if they bring it in, the adhesions are going to recur. Next. Okay, here's one of my patients. She's an interesting lady. She's from Colombia, nurse practitioner, and she does prolotherapy for various physicians. Now, I'm just looking at her here. I said, just take a look and try to see if you can feel anything else that's here. Sternoclavicular joint palpating it, acromion.